Good evening. Thanks to each and every one of you being here with us today. We at Jagsonpal are very pleased to welcome you all to the webinar organized by RN Ganguly Foundation and feel honored to have stalwarts in the field as faculty today. I am Ms. Saxena along with my colleagues Dr. Deepika Chawda from Medical Services, Mr. Prasun Guha and Mr. Subhajit Kundu from Sales, which would like to introduce to you DIVATRONE 10 milligram tablet of Dydrogesterone, which was just recently launched by Jagsonpal Pharma Division. Welcomes today's program moderator, Dr. Mausumi D. Banerjee. Dr. Mausumi D. Banerjee is Vice President, Bengal Ops and Gynae Society and Honorary Secretary, IMA Calcutta branch. She has many publications to her credit and has participated as faculty in many states and national conferences. Dear attendees, if you have any questions, suggestions, clarifications, please post in the chat and Q&A box, which will be taken up at the end. Please note that this RN Ganguly Foundation webinar is streaming live on Facebook. The link is already being shared in the chat box. Also note for future references, we will upload this webinars on Jagsonpal YouTube channel for promotion and reference in the Jagsonpal Medical Insights. And thank you so very much for listening, and let us welcome Dr. Mausumi D. Banerjee to initiate this program.
Good evening, everybody. On behalf of RN Ganguly Foundation, it is our proud privilege and great honor to welcome you all to today's webinar, whose academic partners is Jagsonpal Pharma. And in this, we have a galaxy of eminent speakers. We have our chief guest, the teacher of teachers, Dr. Vaidyanatha Chakrabarty, who needs no introduction. We have with us as a special guest, Dr. Mamta Shangamita. Now, just at the onset, I'm just sharing a small screen about RN Ganguly Foundation. So RN Ganguly Foundation is a philanthropic organization formed in the memory of late Rajendra Ganguly of August 1901 to 1965. Your life was a blessing, your memory a treasure. You were loved beyond words and missed beyond measure. So let's pay our tribute to the great soul, late Rajendra Ganguly, and his better half, late Kiranbana Ganguly, who were great social reformers. He always helped the people in need, helped in spreading the awareness for the need of women education and upliftment of the society. His contribution is still remembered and honored by the inhabitants of Garuria, Bangladesh, his native village. His able daughters, the younger daughter, Dr. Gita Ganguly Mukherjee, and Mrs. Pushpa Mukherjee, and all the family members, being inspired by his lifelong benevolent activities, desired to pursue his unfinished work. And that was a long way to go. Thus, the journey begins. In 2000, Dr. Gita Ganguly Mukherjee, his youngest daughter, the president of ISOPERB, sponsored RN Ganguly Public Awareness Forum of ISOPERB. Many awareness programs on healthcare were organized all over the country and were greatly appreciated in All India Congress of ISOPERB. Inspired by the success, the family members desired for a bigger platform, as thus the RN Ganguly Foundation. The first annual conference, even before the formal registration, was inaugurated by Dr. N. Rai Chaudhary at the PLSN. The foundation conducted the health and public camps in different districts of West Bengal and CMEs in various places in Kolkata and also outside West Bengal. Ultimately, the foundation got registered during 2005 and 2006 by the donation from the family members. And what are the aims of this foundation? Public awareness in education, healthcare, and women empowerment, medical and public awareness camps, academic activities, innovations, annual conferences, CMEs, publications. And these are the few glimpses of the different health camps. Here we see Chhattopadhyay Dr. Gita Ganguly Mukherjee, Dr. Shuranjan Chakravarty, and here we find Dr. Banerjee Chakrabarty, Mumtazi, Kalidas, Dr. Kalidas Bukshi. We have Dr. Gautam Khastagir, Animadi, and we have Omulda, the better half of Dr. Gita Ganguly Mukherjee, who is for this foundation since its inception. So again, the stalwarts in another meet, and the different orations so far were delivered by galaxy of eminent personalities from the various fields of education, fine arts, literature, and also by social reformers. The first orator was our teacher of teachers, Sir Dr. Banerjee Chakrabarty. On 7th annual conference at Porivesh Hogbon, the topic was infertility. Then Dr. Alka Goswami, ex-professor and head Guwahati Medical College, a topic IUGR. Then Honorable Minister Justice Noor Alam Chaudhary on 9th annual conference, and the topic was social aspect of medical profession. Dr. Kamini Rao on 10th annual conference, and fetal origin of adult diseases was the topic. Dr. Sadhna Desai on the 11th annual conference, time to save women's life, EMOC, evidence, ethics, and excellence. We have Dr. Pratap Kumar in the 12th annual conference at brand and quality care in modern obstetrics. Dr. Anima Bishash on health awareness among women. Dr. T.A. Chaudhary from Bangladesh, he gave oration on prevention of birth defects. We have Swami Atma Priyananda on the 15th conference on critical inquiry and the care of education Vedantic perspectives, and Dr. Chandravati on cervical cancer, its prevention vaccine. Then when COVID came, this RN Ganguly Foundation didn't stop, right? So it faced the challenge and went over to the virtual conference, where again the orator was Dr. Prakash Dwivedi, the national president of ISAR. And there are many publication books on IUI, genital tuberculosis. There are these glimpses of various CMEs, the public awareness. And so the virtual meet, every challenge is a challenge to fulfill our dreams of success, and every challenge is a motivation to move a step ahead. So COVID couldn't stop us, and we do have a long way to go. Best wishes to RN Ganguly Foundation and this program, and hope you will all enjoy this program with a lot of take-home message. So without wasting thank you, without wasting much time. Now it is my proud privilege to introduce his able youngest doctor, Professor Dr. Gita Ganguly Mukherjee, a great teacher, a loving personality, and our very own universal Gita Di, well known nationally and internationally. So over to Gita Di for your welcome address, please.
Thank you, Mausumi. On behalf of RN Ganguly Foundation, it is my proud privilege to welcome you all in this web series of RN Ganguly Foundation. As you have heard, that this foundation is a philanthropic organization which does lots of medical camp, awareness program, but along with that, we do CME and also once a year, the annual conference. Last year, we could not do any physical conference, but we have done lots of CMEs and also annual conference. I welcome you all, and you know, I am so glad that Professor V.N. Chakravarty, a living legend in the field of ART, is present here. He's our teacher. He is the teacher of the teacher. Thank you, sir. Welcome you, sir. I welcome Mumtaj, who is a part of this organization. We went to camp several times. Mumtaj also went with me, and Shokripa and other. And I welcome Deepika is here. Deepika Deka, and Ramprasad Dey is here. Ramprasad is the secretary of our beloved BOGS, and he is the professor of GNO in Chittaranjan Shivasadam. Sita Ramurthy is a new thing. He's so energetic, Sita. Welcome, Sita. You know what's happened? He is working so nicely in BOGS, in RCOG, in ISOPAR, and also in the Fetal Therapy Society, isn't it, Sita? Okay.
Medicine.
Yes.
Fetal medicine.
Fetal medicine.
Fetal medicine, yes, fetal
Right.
medicine. Then Mausumi, you know, all the time. We cannot do any CME without Mausumi. And Ratnavali. I told Ratnavali, you must come, and everybody know her. Kalidas Bokshi, KD Bokshi is one of us. And here is Avinash. I don't know how many times I rang all of you. I welcome all the chairpersons and the speaker so that they can come and join this thing. Otherwise, this seminar will not be. Tulika is here, is the clinical secretary of our beloved BOGS. Sir, Professor B.N. Chakravarty, sir, everybody is waiting to talk to you after your lecture because you give them blessings that all young beggar is coming up. And Tulika, Sita, Mausumi, and Sudhir is here. Sudhir is Bulbul is the backbone of this foundation. Now we are doing this web CMEs for last year and this year also. I hope in the next year the condition will be better and we can do the physical CMEs and webinars. Now Sabnam is here, the young infertility specialist, and who is, no, everybody, I think they are coming, they are coming. Now with this, I welcome everybody, and Deepika Samra, I welcome you very much. You arrange this thing and you meet and you come to Calcutta so that you can meet in the physical conference all this time. And we must tell Shubhajit. Shubhajit is a Jagsonpal company, and I congratulate and I thank you, Jagsonpal company, for conducting this meeting. Thank you very much. I welcome you once again. Thank you.
Thank you.
Hey, Ratna, one thing. Ratna is here, and Ashis. You are not doing, but you are also all the time coming and participating in this conference. I'm very glad. And with not here, everybody is here. Sir, you must know Ramprasad. It's very important. The important secretary and the beloved secretary of BOGS. Deepika Deka. Deepika, you know everybody, isn't it? Yes. Now Mausumi.
Yes, welcome, Madam.
Yes.
Deepika Deka.
Thank you. Yes.
Yeah. And Madam, when you call everybody, all of us are always, we always agree to your call. We could never say no to you.
That
So
I
we are
know.
always there
That
with
I
you.
know.
Yes. And today also we are together and hope this program will be a great success with a galaxy of eminent faculties, and sir is there, our grand teacher of teachers, and we'll have a lot of take-home message. Now, we come over to the auspicious moment. Om Oshatama Shat Gamayo, Tamoshama Jyotir Gamayo, Mriturma Amritam Gamayo, Om Shanti, Om Shanti, Om Shanti. From ignorance, lead us to truth. From darkness, lead us to light. From death, lead us to immortality. So now is a moment of lighting the lamp of knowledge. Our teaching of teachers, lovely professor, joining hands in lighting this virtual lamp of knowledge. May we welcome Dr. Momta Shangamita as the guest of honor to say a few words. Momtazi is a past MP and also the ex-head of the Department of Eden Hospital. She's renowned everywhere, not only for her academics and her work, and also for the cultural activities. And she is associated with RN Ganguly Foundation for a long time. So, Momtazi, your address.
Thank you, Mausumi and Gita Di and Ratna and who all called you. I was, in fact, in another meeting, but anyway, I wanted to make it. So I'm making, I just could be present. I'm very thankful. And first of all, as you said, I am associated with the RN Ganguly Foundation in the call of Gita Di since its inception. And as you said earlier also, you all, I don't know what charisma Gita Di has got. She can call upon any age group of people, of any knowledge people, and everybody will come to her call. And he has got a knack to the knack of asking or doing things with all of us together. So that is how this RN Ganguly Foundation became bigger with a always having a scientific and other social activity extravaganza in RN Ganguly Foundation, which is in the name of Dr. Gita Ganguly's father, who was very keen on education, especially the female education and all. And Gita Di being no brothers, 4 sisters, and whom we can see how he and Gita Di's mother must be. They have imbibed the quest of knowledge and teach public to his daughters, and one of the most important of them is the youngest daughter, like Gita Di, and who again has imbibed all of us in her and involved her us. So we are, thank you Gita Di, and day by day the RN Ganguly Foundation is being enriched with the scientific, especially always we had as a head, as our sir, Professor Chakrabarty, and who is the teacher of the teachers, and who is there to advise us, who is overall. So we are very lucky to sir as a still is doing everything like a person will do, and he is going on to creativity with the creativity of the students as well. Thank you everybody. Now we'll go ahead with our further functions. Thank you.
Thank you, madam. Now we are over to the inaugural speech of our sir, our grand teacher, teacher of teachers, Dr. Vaidyanatha Chakravarty. Everyone knows him. He needs no introduction. His biodata is huge, and he is the director of the Institute of Reproductive Medicine, IRM, and the ex-chairman of ICMR Committee for formulating national guidelines for regulation, supervision, and accreditation of ART centers in India. He is a convener postdoctoral fellowship course in reproductive medicine, National Board, Ministry of Health and Welfare, past visiting professor of the various hospitals in Bombay, in Saudi Arabia, in Chandigarh, in Pondicherry. He has got a lot of research collaborations and a lot of awards, many books, many publications, and his current research interest is on endometrial receptivity and recurrent miscarriage, the Luteal Phase defect, and he has got the honorary membership of International Federation. And in September, just a minute, Federation of Fertility Societies in September 2016. So over to you, sir, for your inaugural speech. We are all waiting to hear you.
Yeah.
I want to tell one thing. Sir is the trained philosopher and guide. He is always with this foundation since the inception. And we always get advice from him. We get the blessings for him. And that's why our pranam to sir. Now, sir, we'll talk to.
Thank you very much. Good afternoon. As I said, my sons and grandsons, and a teacher and a grand teacher. Throughout my life, I have talked. Seldom I have heard. So today I thought that Gita has asked me here to come only to learn and not to teach. And therefore, I didn't want to talk much. Neither I have the capacity at the present moment. But I want to say a few words. Bless Gita and her friends and my good, very close friends in the audience and who are listening to me. Now, I am associated with this organization since its inception. I don't remember which year, but I think I was the first orator.
Yes.
And gradually, when I went to it, I was the first orator, I think, of this foundation. Somebody, Dr. N.N. Raituri, or Noganda, beloved Noganda, he inaugurated it when he was the president of, I think it was Foxy or Bogus, I don't know. But anyway, he inaugurated that much, I remember. And two things fascinate me about Gita and Gita's activities. She is a lady, or she's just like my. I thought he was just like my daughter. No, I find now that his father, beloved father, Dr. RN Ganguly, was born in 1901, the year in which my father was born also. So from that point of view, there is a similarity. So I think it is a foundation and rather philanthropic organization held every year, and his able daughters, I'm so jealous about him that his daughters are so much attached to him that instead of spreading his name, she wants to spread her mother's name. He has made tremendous amount of work in this discipline, in the discipline in which you and I are working. And it is a great attachment, it is a great awareness that she has put everybody to work, her friends, our family members to build up this association in the name of his father. And the aim, I'm associated with this organization since its inception as a friend, philosopher, and guide. I remember the first oration in the 7th annual conference in Porivesh Bhavan, Kolkata. I delivered that lecture. And I attended as chief guest in their programs organized so wonderfully throughout the years. And since its inception up till today, I am 93, 94 today, there has been no occasion when I missed the annual conference of RN Foundation, organization. It's a philanthropic organization formed in the memory of his father. That is, he was a great social reformer and always helped people in need. And his contributions are still remembered by the people of his native village somewhere in Odisha, and that is in Bangladesh. Borishan colloquially in our East Bengal, as you know, the Jeseshal, Arseshal, their name Borishan. So, and in fact, by seeing Gita and Gita's family, it does not look like that. I think on the other hand, it looks like that they are philanthropic worker, and Gita and Mr. Ganguly's daughters desire to pursue his unfinished work, and ultimately RN Ganguly Foundation was founded by the family members. I don't know, or I don't remember, I don't know whether my associates also remember that any doctor within our knowledge has not done so much to make father or mother unmemorable by his unfinished work. And RN Ganguly was one of those lucky men to have a daughter like his daughters like Gita Ganguly. Now, are held today's CMEs are held. This is a very important subject and will be discussed here. We will be listening to that, such as luteal phase defect, my very favorite subject. You know, Dufaston is very much associated with me, and fetal therapy. I am glad to see that senior professor as well as young ART specialists are delivering the important talks. Dr. Kanchan Mukherjee, one of the pioneer neonatologist or rather fetal medicine professor speaking on multi-fetal pregnancy reduction, which is so important in IVF. Diagnosis of fetal anemia is difficult, which will be dealt with, and Sitaram Municipal and Deepika Deka will be delivering intrauterine fetal transfusion. Dr. Ramprasad Dey and Dr. Ashis Mukherjee will speak as luteal phase support. Now, I have just renamed this luteal phase support as luteal phase support, or another very important topic is dydrogesterone. Dydrogesterone, I was very much associated, or rather, I don't know why, with dydrogesterone and your letrozole. So you know that the story. For letrozole, I had to suffer some legal action also. Not suffer, going to suffer, but somehow or other I escaped that. And I find I'm very happy to see today that luteal phase support, that letrozole has been accepted legal in Indian market. Dr. Gautam Kasturi, I'm very happy Dr. Gautam is speaking on that subject, and I had many publications on letrozole and dydrogesterone. Yes, and aim of this foundation is to organize public awareness programs and health camps, academic activities through orations, CMEs, and annual conference. His able daughters, Gita Mukherjee, Pushpa Mukherjee, and they were very much associated, closely associated with my wife. I don't know, they used to call call her as their sister, and still the relationship is going on. And one very particular coincidence has been there throughout my professional career. I have been very close to Gita in her professional activities, right from Nilratan Sarkar Medical College up to this place where I am retiring and passing away probably. And Gita has been with me and Gita has followed me. And why you are so keen and follower for me, I don't know, but somehow or other, it is a coincidence. The posting, the posting, the public work, and the academic activities. Apart from academic activities, the professional activities has been very much linked with Gita's professional activities. And I thank you, Gita, and for your great affection and love for me, and love not for me, but for the patient. And you have done much. I have seen her throughout the professional life, right from 1955, I think. And up till today also, she has not been separated from me. Thank you very much for all these organizations, and she's still having the courage of doing these things and getting in touch. So I congratulate to the young daughter of Mr. RN Mukherjee for carrying the the glory of the foundation with utmost sincerity, even in the COVID times. Thank you very much, and thank you for inviting me for this blessing that I wanted to give. And I am showering my wholehearted blessing and for your future improvement and future activities. Thank you, and thank you all the members of RN Ganguly Foundation Awareness. Thank you very much.
Thank you, sir, for your blessings, and pranam to you, sir, on behalf of everybody in this forum. And you are the friend, philosopher, and guide of this organization since its inception, and we are looking forward for your guidance also in the future years. Wish you good health and best wishes, sir. Thanks a lot. And now we are passing over to our Gita.
One thing, sir, Dr. Deepika Deka will talk on the intrauterine fetal constitution. Dr. Deka is here. Her lecture is the last, so I cannot ask you to be present here. Anyway, that is a very good lecture. Another thing I want to tell everybody that Sir's book, the 4th volume, is already published, but you'll get it from the medical shop, I think after a month, isn't it? The 4th volume of your book. Ratna?
Yes,
Isn't
yes, yes.
We'll get after a month.
Yeah, within a month.
So I want to try to get one copy of that. It's very important. Okay.
So with all your blessings, we are passing over to the first scientific session on a very interesting topic on luteal phase defect. And for this, may I welcome Dr. Ratna Chattopadhyay. She doesn't need any introduction. She is an infertility specialist in IRM and the chief embryologist. And so she has got many papers. She joined many conferences. And another chairperson with us is Dr. Shiuli Mukherjee. She is Secretary of Hisar, Bengal, and she is the director of Mukherjee Fertility Center, MFC Women and Child Care, Howrah. So we have our eminence speaker today, Dr. Sabnam Parvin. I'm requesting the chairperson to introduce the speaker and conduct the session. I'm requesting the speakers to kindly maintain their time limit of 12 minutes.
Good evening, everybody. I am feeling honored to be a part of this prestigious symposium organized by RN Ganguly Foundation. As usual, I am thanking or rather thankful to our beloved and respected Madam Dr. Gita Ganguly Mukherjee for giving me the opportunity to moderate a topic in the session of luteal phase defect, a very controversial but still relevant topic or aspect in the treatment of infertility. The present topic is what is luteal phase defect, and the speaker is our beloved Dr. Sabnam Parvin. She is the promising infertility specialist of the city. She completed or she did her graduation in medicine in 2012, and she achieved diploma of National Board in Obstetrics and Gynecology in 2017. And then she completed her postdoctoral fellowship of National Board in Reproductive Medicine from IRM, Kolkata, under the guidance of Professor B.N. Chakrabarty sir. She presented scientific paper in national and international conferences and has been awarded for some of her presentation, and she contributed chapter. She is very fortunate and lucky. She contributed chapter in a book edited by Professor B.N. Chakrabarty sir. That is a book, Clinics in Reproductive Medicine and Assisted Reproductive Technology. Now I am requesting Sabnam to start your presentation, please.
Thank you, ma'am, for your kind introduction. A very good evening to the respected chairperson, my seniors, and all my colleagues. First, I'd like to thank Professor Dr. Gita Ganguly Mukherjee for giving me this opportunity. Thank you, ma'am. So my topic is, what is luteal phase defect? So there is a lot of controversy still as to the actual independent existence of luteal phase defect. So before we go on to the topic, I'd like to take a quick glance at the physiology of normal luteal phase. So as we know, the menstrual cycle consists of 3 distinct phases: the follicular phase, then the ovulation, and the luteal phase. The follicular phase is an orderly sequence of events under the influence of various hormones and autocrine paracrine peptides, which lead to the selection of one primordial follicle, which goes through various stages: the preantral stage, the antral stage, and the pre-ovulatory stage, finally undergoing ovulation, giving rise to the corpus luteum and the beginning of the luteal phase. The primary objective of normal luteal phase is to build an optimally receptive endometrium to allow the mature blastocyst to implant under the influence of 2 steroid hormones, mainly estrogen and progesterone, the source of which is the corpus luteum. So as the saying goes, as we sow, so shall we reap. So the prerequisites of a normal luteal phase is an optimal pre-ovulatory follicle development, followed by an optimal LH surge and subsequent ovulation. For an optimal pre-ovulatory follicle development, adequate FSH levels, normal FSH-LH ratio, normal FSH and LH pulses in the follicular phase, adequate pre-ovulatory estrogen levels, adequate LH receptor accumulation is required. Following ovulation, the proper formation of the corpus luteum, the optimal vascularization of the corpus luteum and its function is required. A continued tonic LH secretion maintains the function of the corpus luteum, and even after adequate presence of estrogen and progesterone, an optimal endometrial response is required for the changes seen in the normal luteal phase. In case of pregnancy, adequate beta-HCG levels will be required to maintain the corpus luteum and the progesterone secretion. So what are the events in a normal luteal phase? At the ovarian level, just before ovulation, there is the enlargement of the granulosa cells, vacuolations are formed, lutein accumulation takes place, and just after ovulation, the enlargement of the granulosa cells, the theta lutein cells, they continue, and there is vascularization and corpus luteum is formed. The corpus luteum starts secreting estrogen and progesterone. By days 8 or 9 of ovulation, peak estrogen and progesterone levels are reached. 9 to 11 days post-ovulation, if not rescued by HCG, the corpus luteum function decreases, and under the action of endothelin-1, prostaglandin F2 alpha, TNF alpha, matrix metalloproteinase, luteolysis occurs. At the endometrial level, in an estrogen-primed endometrium, various changes are seen, like the glands become tortuous, corkscrew-shaped with large lumens. The progesterone induces the endometrial glands to secrete glycogen and mucus. The spiral arteries undergo branching and spiraling and extend to the superficial layer. There is residualization of the stromal cells. There is leukocyte infiltration. In the absence of pregnancy, endothelin and thromboxane leads to vasoconstriction and necrosis, and degradation is facilitated by matrix metalloproteinases, which finally leads to menstruation. At the molecular level, the estrogen, it upregulates the progesterone receptors, VEGF, insulin-like growth factor, L-selectin. The progesterone brings about the morphological changes, pinopode formation, upregulates the leukocyte inhibiting factor, the mucin-1, L-selectin. Apart from estrogen and progesterone, there are a number of molecules which are upregulated during this luteal phase, like cytokines, growth factors like TGF-beta, insulin-like growth factor 1, vascular endothelial growth factor, and various genes are also expressed during this period, like the HOXA10 and 11 genes, which promote the decidualization of the endometrium and makes the endometrium receptive for the embryo implantation. So, considering the normal luteal phase physiology, the following observations can be made. Luteal phase length is relatively fixed at 12 to 14 days. It may range from 11 to 17 days. The progesterone levels peak 6 to 8 days after ovulation in non-pregnant females. A value of more than 3 nanogram per ml is indicative of ovulation. The progesterone is secreted in pulses under LH control. They are more pronounced in mid to late luteal phase and may fluctuate up to 8-fold within 90 minutes. The endometrial response depends on the follicular phase estrogen, which causes the priming of the endometrium, and then the luteal phase estrogen and progesterone, which brings about the decidualization. After implantation, the maintenance of the corpus luteum and the progesterone secretion depends on the HCG levels. So coming back to our original question, what is luteal phase defect? It is a condition in which ovarian hormone production is not of a sufficient quantity or temporal duration to maintain a functional secretory endometrium and allow normal embryo implantation and growth. It was first described by Sir Georgiana Cigar-Jones in 1949. The initial criteria was a blunted or shortened basal body temperature, or low 48 hours urinary pregnanidiol excretion, or inadequate or discordant secretory changes in premenstrual endometrial biopsy. Even after 70 years of its definition, luteal phase defect has not been proven to be an independent entity causing infertility or recurrent pregnancy loss. Controversy exists regarding the multiple proposed measures for diagnosing luteal phase defect and assuming it can be diagnosed accurately, whether treatment improves outcomes or not. So what is the criteria of defining luteal phase defect? So if the luteal phase length is less than equal to 10 days, then we can call it clinical luteal phase defect. In case of low progesterone levels during the luteal phase, it is known as biochemical luteal phase defect. if there are discordant secretory changes in the premenstrual endometrium, then it is known as histological luteal phase defect. There are various controversies regarding these criteria. The first is the luteal phase length. The luteal phase can be calculated by LH detection kits or basal body temperature from the luteal phase peak to the onset of menstrual flow, but the duration varies from 9 to 11 days in various definitions. 13% ovulatory cycles have luteal phase less than 10 days without affecting the fecundity over 12 months. So basically there is an overlap in these shortened luteal phase cycles between fertile women and infertile women. So it is still unclear whether it is an independent cause of subfertility or pregnancy loss. Then due to the pulsatile nature of progesterone release, it has not been able to define a normal threshold peak, trough, or average concentration in the natural cycles. The progesterone levels may vary from 5 to 40 nanogram per milliliter. So a single value is not enough to diagnose luteal phase defect. In ovulatory cycles itself, progesterone less than 5 nanogram per ml occurs in 8.4% of the times and less than 10 nanogram per ml in 31.3% of the times. And also there is intercycle variability. In model cycles, where we use estrogen and progesterone to form the endometrium, a threshold value of 2.5 nanogram per ml for normal endometrial histology and a value between 8 to 18 nanogram per ml is required for normal gene expression in the endometrium. So a few studies have shown that instead of taking a single value, we can take multiple readings of progesterone, but taking multiple readings is impractical and is not clinically validated yet. Coming to the histological dating, it uses traditional microscopic appearance of luteal phase development and is observer dependent. It doesn't take into consideration various factors like the steroid receptors, the growth factors, the proteins, the cytokines, the pinopodes on endometrial receptivity. Also, the maturation may be different in various sections of the endometrium. Hence, it doesn't give a global picture of the endometrium. In this also, it shows cycle to cycle variability. Studies have shown that up to 25% of the biopsies,
at the end,
particularly women, may show maturation delay. So due to all these reasons, defining a criteria for luteal phase defect is still controversial. Coming to the causes of luteal phase defect, any condition which disrupts the normal GnRH and the LH pulsatility may cause luteal phase defect. Some examples are hypothalamic amenorrhea, eating disorders, excessive exercise, significant weight loss, stress, obesity, polycystic ovarian syndrome, endometriosis, aging, thyroid disorders, hyperprolactinemia, ovarian stimulation, progesterone-resistant endometrium, and idiopathic. So to conclude, I'd like to say that though luteal phase defect can be considered as a consequence of various pathological conditions affecting the follicular phase or the progesterone secretion or action, its independent existence as a cause of infertility or subfertility or pregnancy loss has not been established yet. So more research is required to overcome the obstacles in defining its criteria so that better tools for its diagnosis and prevention or treatment can be ascertained. Thank you.
Thank you, Sabnam.
Thank you.
It's very nice lecture you have done. I'm very proud of you. Thank you. But question answer will be at the end of the session.
Yes,
Ratna.
Thank you, Sabnam. So, yeah, it is a wonderful and informative presentation. You nicely explained what is luteal phase defect, covering both physiological and immunological abnormality, because we have the idea that for successful implantation of an embryo, a helpful immunological environment is needed. And for that, and effective changes in the endometrium is required. We just learned all these things from our respected sir, Professor B.N. Chakravarty. But you nicely mentioned that still the role of this luteal phase defect behind infertility or pregnancy loss is debatable. Thank you. Thank you very much.
Thank you, ma'am.
Keep it on, Sabnam,
Thank you, ma'am.
and present the paper in many conferences. Thank you.
Ma'am, thank you.
Yeah, thank you, Sabnam, for your wonderful lecture. And may I thank also the chairpersons. And now we are passing over to our next session. I'm requesting everybody, if you have any question, kindly put in the Q&A box. We are going to discuss with all the eminent faculties at the end of this CME. Now, our next session, where I invite, so may I invite Dr. Professor Sudhir Adhikari. You know his designation as ex-HOD Department of OB-GYN, North Bengal Medical College, ex-professor, Medical College, Kolkata, Midnapur Medical College, IPGMER, BS Medical College, Bakura, and is the past president of our Bengal Obstetric Gynecological Society, organizing chairperson of IMS conference in Kolkata 2019, organizing chairperson IAG conference in 2019, many awards, many publications. So over to you, Shudita. Dr. Jayita Chakrabarty will not be able to make it today because of our emergency commitments. So the stage is yours. Kindly introduce our speaker, Dr. Ramprasad Dey. Shudita.
Yes. Thank you, Mausumi.
Dr. Sudhir Adhikari, please.
Yes, can you hear me?
Yes, you can hear.
Yes, yes. Shudita, are you here?
Yes.
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 You can hear.
Shudita, introduce Ram.
Dr. Ramprasad Dey.
Yes. Dr. Ramprasad Dey is the professor of Chittaranjan Seva Sadan and honorary secretary of Bengal Obstetrics and Gynecology Society. He has received many prizes from national award, these Foxy conferences, and he is the executive member of ISUPAR, Joint Organizing Secretary of All India Congress of Obstetrics and Gynecology to be held in Kolkata 2023. He is the national corresponding editor of Yogi, joint editor Indian Journal of Perinatology, examiner of MBBS, DGU, MD in many universities of our India. And he's even paper setter, and he has got in his credit so many publications, and he's a peer reviewer of different journals, including Indian Journal, Gynecology and Obstetrics. He presented more than 40 papers in different conferences, including international conferences. So Professor Ram, he will speak on diagnosis of luteal phase. As you have heard from Sabnam, what is luteal phase, and it is still difficult to understand and still difficult to diagnose and still difficult to management also, and especially for infertility. Thank you, Ram.
Yes.
It is your turn.
Am I audible? Yes.
Yes.
Thank you, Dr. Professor Sudhir Adhikari, for my kind introductions. Thank you all the dignitaries, particularly our teacher of teacher, Professor B.N. Chakrabarty, as today's inaugural, as well as the guest of honor, Dr. Mumtaz Madam, as well as the Dr. K.D. Boxi. I can see him. And before going to start, I must thanks to Professor Gita Ganguly Mukherjee, our beloved Gita Di, for giving me the opportunity to talk on this luteal phase defect. And it is a privilege and honor for me and to share with the screen where that Professor B.N. Chakrabarty and Gita Di also here is conducting the CME, and I am associated with RN Ganguly Foundation, the CME. So once again, good evening to everybody. My topic of discussion is the diagnosis of the luteal phase defect. I think my previous speaker has already told us what is luteal phase defect, and he has done almost how to diagnose also the luteal phase defect. She is an infertility specialist, so He has clearly said that it is not possible to diagnose as a luteal phase defect. What are the different parameters in the endometrial biopsy or mid-luteal progesterone estimation or only the history second? Let's you allow me to speak as a perspective of general gynecologist, as a teacher of gynecologist, to luteal, how to diagnose the luteal phase defect. Just to introduction, my previous speakers Parvin has already told, it is the Segar-Jones in 1949 has described this luteal phase deficiency. Luteal phase deficiency as described as a condition which ovarian hormone production is not sufficient quantity or temporal dominance to maintain the functional secretory. Clinically detected from the history, the luteal phase defect is less than 10 days, or it is in the other stage it is less than 9 days. Some other author says it is less than 11 days. There is alternate biochemical definition also. I am coming to my discussion during the luteal phase defect diagnosis. So before, though the physiology part has been already told, but still how to diagnose the luteal phase defect, you have some basic knowledge from the history taking. So the physiology of the luteal phase defect is also important, because beyond this physical test, you may have to suspect that yes, you are dealing with the presence of the luteal phase as a general gynecologist before sending the patient to the infertility specialist. The typical luteal phase delta, which I've already told, this is 12 to 14 days, but it can range from 11 to 17 days. So there is a great dilemma. Progesterone levels in the mid-luteal phase in the non-pregnant cycles, it is the 6 to 8 days, all of you know, after the ovulation. Progesterone is secreted in a pulsatile form, and there is a fluctuation of the progesterone value also. The endometrial reflection, yes, it is not only the progesterone. It has been so many studies that prove that low level of progesterone do not produce also the clinically significant pregnancies produced. So it is not only the luteal phase, or the good progesterone does not have the capacity to implant in the endometrium. So the endometrium reflection is also important, and this endometrial response is not only starting with the luteal phase, but it also starts from the follicular phase on the estrogen, which is estrogen dependent, and the luteal phase, which is the estrogen prime endometrium, is progesterone dependent. So both is also important. Once the implantation occurs, the progesterone, I think all of you know that it is secreted by the corpus luteum on the stimulation by the human chorionic gonadotrophin. So failure of HCG levels also to help you that directly or indirectly that there is a corpus luteum failure and decreasing progesterone level. I am not going to that, but what I am wanting to highlight, the luteal phase, the three cycles. The one is the hormonal cycle, one is the endometrial cycle, one is the ovarian cycles. So if you start with the luteal phase is the corpuscular phase of the ovary, it starts after the ovulation. So the questions of luteal phase, dealing with the luteal phase deficiency, whether patient having luteal phase deficiency or not, you may think in indirect way whether the patient at all ovulated or not. So without the ovulation, you may not think of that there is a good luteal phase. So the indirect way, what I am trying to say, that luteal phase defect is as there is a difficulty in diagnosis of luteal phase. But if you expect you dealing with the phases which have a good ovulation or the natural cycle menstruation with the natural ovulation, that patient may not have luteal phase defect, but may have also. But if a patient with a dealing of the anovulation, the question does not arise that you are dealing with the luteal phase, because the patient has not entered into the basically in the luteal phase. So from the diagnostic point of view as a clinicians, the detection of ovulation, though the luteal phase defect diagnosis is difficult, but nowadays the detection of ovulation is much more easier. So whether the patient at all has the ovulation has occurred, whether she has entered into the phase of luteal phase, indirectly you might take the history or some investigation with the patients having the ovulation or not. These are the investigate how to detect the ovulation. I am not discussing, this is not my topic. But what is I wanted to highlight, if you think is the pregnancy is the surest sign of ovulation, keeping in mind it is not the surest sign of having a good luteal phase or normal luteal phase. That means if the ovulation occurs, pregnancy occurs, then you are sure that ovulation occurs, but it does not exclude the luteal phase defect. So a changing scenario, I'm not going to the detail. What are the changing scenario of ovulation? What are the tests for ovulation detection? All of you know, and I'm not, because here is so many infertility specialists, they know far better than us. Now coming to the pathophysiology, Joe, this is the Parvin has already told us the pathophysiology. Why I am talking the pathophysiology? Because the luteal phase defect is still under investigations, still under research. So if you think of the pathophysiology, how the luteal phase defect So you may have some new one your avenue to confirm or to have an additional diagnostic tool, which we have already, to add some things for the luteal phase diagnosis. So the abnormal folliculogenesis is, if it is a patient having abnormal folliculogenesis, you might have suspect that patient may have a abnormal luteal phase also. Inadequate LH search or premature LH search, a chance of luteal phase defect. Inadequate progesterone production by there. But last but not the least, the aberrant endometrial organ response by the endometrium. Also, you have to think of the indirect way of diagnosis luteal phase defect. So if you then look up this pathophysiology, which may help you for the diagnosis or have some given a avenue for the future diagnosis, two mechanisms is important for the luteal phase. One is the impaired production of the corpus luteum, and second mechanism, the inadequate or unresponsive endometrium to this progesterone is a luteal phase defect. So impaired function can be result of poor development of the dominant follicle. So when you are dealing with the patients from the follicular phase also, that might, you have suspect that there is no such proper development of dominant follicle, that may patient, or that the aberrant stimulation from a normal developed follicle, you may suspect the patient may have a luteal phase defect. Now coming to the both the mechanism result in the inadequate production of progesterone, and multiple studies have found correlation with the low follicular FSH and the luteal phase defect. That means always it is not, you will just go to the luteal phase to the diagnosis of the luteal phase defect. So the earlier increase in the LH pulsatile frequency in the early follicular phase, that is the premature follicular in the luteal phase, decrease the LH activity in the luteal phase, and subsequently leads to the decreased production of the progesterone and also the luteal phase defect. Second part is important also, that the endometrium responsive also, that is the estrogen prime endometrium, how it works with the progesterone exposure, that is also important. So inequably low, sometimes the low progesterone also produce complete normal endometrium. Sometimes the normal progesterone level is also does not having the normal endometrium is not responsive. So keeping in this mind to this pathophysiology, you have to diagnose the luteal phase defect. In the 2012, the ASM, that is the American Society, has described there is a no reproducible physiological relevant and clinical practical standard to diagnose LPD or distinguish it from the fertile from the infertile woman. So my job is very difficult how to diagnose luteal phase defect. Now we are in the 2021. Now end of the talk, I will also say what the latest, that is the ASM saying to diagnose of the luteal phase defect. Now, to diagnose anything, you have to suspect that to whom you diagnose this. So suspicion is important, and the patient selection, then you should not go for the all patient to diagnose luteal phase defect. So from the history taking, so the luteal phase, for the patients who may dealing with the luteal phase, patient selection, choose a test which is sensitivity and specificity, that means which detect all the which exclude the all false positive and false negative. This is the basically the all test has the criteria for diagnosis. In whom to suspect and offer with the patient for the luteal phase defect, patient having unexplained infertility, advanced maternal age, recurrent abortion, and the exercise related or some sort of that. But these 3 or 4 is not sufficient enough only patient for the luteal phase defect. What are those? There is a lot of patient condition associated with the luteal phase defect. Yes, topmost is the infertility. Second is the second trimester pregnancy loss. You may, first trimester pregnancy loss. Short from the history, the short menstrual cycle less than 21 days. Premenstrual spotting, patient having history of anorexia, starvation, or eating disorder. Aged, more than 35 or 40 years, you may suspect. Associated endometriosis may lead to luteal phase defect. Is the endometrium is also defective. Inadequate treated 21 or some of the hormonal deficient. But another thing also, last but not the least, also very, very important, the assisted reproductive training, because you have give some stimulation, you have to ovum retrieval, so you may suspect that this patient having a luteal phase defect. So the proper diagnosis test for the luteal defect, what are the proposed things from you? You can diagnose the luteal phase defect. Number one, the history taking, the short luteal phase based on the menstrual cycle length. We have a fixed idea that the luteal phase, that the post ovulation phase, the normal cycle is always fixed. It is the proliferative phase, but in case of luteal phase defect, that period is shortened. the shortened luteal phase based on the basal body temperature, the measurement of single and multiple serum progesterone level. I am coming how the progesterone will help, or it is not at all helpful. Endometrial biopsy, though earlier books suggested, or the history suggested, historical, it is the gold standard, but it is not always true. Transvaginal sonography and other endometrial markers. These are the things which is available for the diagnosis of the luteal phase. I am coming one by one. So from the history taking, which I have already told, the average luteal phase length is a normal woman is 14 days. It is almost fixed. But in the luteal phase defect, it may varies from 11 to 7 days. Average is 10 days. Some says 9 days less than to be stamped as the luteal phase. However, this method is inaccurate, inconvenient, and should be discouraged. So only the history taking the menstrual cycle length is not suggestive of luteal phase defect. Menstrual history, I think the history taking, these are the menstrual history which may suggest that patient have a ovulation, but it does not always suggest the patient have a good luteal phase. These are the things for the ovulation, but a woman with cyclical means menstruation at interval of 25 to 30 days and duration of 3 days is likely to be ovulating. With this history taking, you may have to have that patient is ovulating, but whether this patient having adequate luteal phase or normal luteal phase, it is very difficult to predict. Now coming to the basal body temperature, it is very much important on the point of view of the clinician for the previously for the ovulation detection, but keeping in mind the progesterone is thermogenic, there is a temperature range from 97 to 98. This is also basically for the test for the ovulation, but it might give some helpful for the normal luteal phase. If you look at this, in case of normal luteal phase, there is a biphasic pattern of the biphasic pattern of the thermogenic curve. So you may suspect, you may think of that patient have a good luteal phase, but where there is the abnormality of the luteal phase, there is a low flat monophasic curve, or you may have some discoordinated luteal phase or short luteal phase. These are the graph of basal body temperature. You may suspect, but these are not full proof for the diagnosis of the luteal phase defect. Now what is the actually role of basal body temperature? It is inexpensive, though limitation, unable to prospectively predict ovulation, subsequently also predict the luteal phase defect. There is a correlation of basal body temperature with serum progesterone level, but it is not always good, and it is not always also helpful that you are dealing with a patient of luteal phase defect. Now coming to the mid-luteal serum progesterone, currently it is routine test for ovulation, but it is you can do it for detection of the luteal phase defect. Now how it is evidence-based, I am coming to that. It is generally done in 20, if you do a single 21 to 23 ideal 28-day cycle, a level more than 3 nanogram per ml in indicating of ovulation and value more than 10 in indicates of both progesterone effectivity and good luteal phase. However, single measures lacks a sensitivity at the progesterone in the secret radicals, and mid-luteal levels of progesterone is a predictor of ovulation, but not absolute predictor of the inadequate luteal phase. Again, I am reporting that mid-luteal progesterone is a predictor of ovulation, but is not absolute indicator of adequate luteal function. So what we have to do, coming to this, as per the ASRM guideline, progesterone is secreted in pulsatile panel in response to LH pulse, with progesterone value oscillating between 5 to 40 nanogram over a short period of time in normal ovulated immunity, making a single random measurement difficult to interpret for the luteal phase defect. Then what to do? The entire period and intricated luteal phase progesterone value of less than 80 nanogram per ml represented the bottom of the 10th percentile of the cycle has been proposed as a diagnostic test for luteal phase defect. That means you have to take the 10 days of luteal phase progesterone, and with this summation, if it is less than 80, you may suspect, but it is not possible that you should estimate the entire 10 days of the progesterone levels to have a diagnosis of luteal phase defect. That is why what we will have there, that the impractical daily serum testing, but 3 daily luteal progesterone defect ovulation between the luteal phase of 5 to 9. It is that total less than 30. That instead of doing 10 estimation, 3 daily luteal progesterone value obtaining between the luteal phase days 5 to 9. Yes, the luteal phase. If you have a diagnosis of ovulation, the day of ovulation, it is easy to diagnose for the infertility specialist. From that point of view, from the 5 days to 9, 3 days menstruation, if it is less than 30 nanogram, then you have a proposed and alternative diagnostic criteria for luteal phase defect. That means what I am trying to prove, that single measurement is not possible to diagnose. Whole luteal phase progesterone is not also possible. So what is the working formula? Practical formula: 3 daily luteal phase in between 5 to 9, and it is totally less than 30 milligram. You may have an alternative diagnostic criteria for luteal phase defect. So in combination with the history taking from the menstrual cycle as well as the mid-luteal progesterone testing, clinically the luteal phase clinical diagnosis is less than 10. Biochemical diagnosis, woman having mild luteal progesterone level less than 5, and clinical and biochemical level associated with the lower follicular estradiol, lower luteal estradiol with the lower luteal progesterone and light and menstrual flow. These combination may help in diagnosis of the luteal phase. Yes, coming to the endometrial biopsy, I think all of you know the 2 days lagging behind is called the luteal phase defect of the endometrium, and each day of the endometrium, that like first day is the subnuclear vacuolation starting from, is precisely concise which day we are dealing with if it is 2 days behind, but it is not possible in the each cycle to do endometrium, because problem is that in which cycle you are diagnosing endometrial biopsy from the luteal phase, that may not occur in the subsequent cycle. So it is retrospectively after doing that, you can say it is that cycle was luteal phase defect, but when you are dealing with the upcoming cycle, it is not possible to diagnose with the endometrial biopsy. But doing endometrial biopsy, you may exclude the other disease also. So this is the picture of the proliferative and endometrial secretory endometrium. So what is the role of endometrial biopsy? Abnormalities of the endometrial maturation have been viewed historically as a gold standard to diagnose luteal phase defect. This is historically gold standard. Out-phase biopsy to diagnose luteal phase by finding of lack of 2 days is not practically possible. But again, what I am trying to say, it can retrospectively diagnose the previous cycle luteal phase, but the cycle we are dealing with, that whether this cycle is having luteal phase or not, because not possible, because previous cycle luteal phase defect may not subsequently occur in the next cycle. Theoretically, the maturation of the endometrium is delayed by the inadequate ovarian hormone progression, or is delayed because of intrinsic endometrium. This is also another important point. Only the progesterone, it is the defect in the endometrium or defect in the progesterone. It is not clear that because the endometrial defect, which already has told previous chairperson, the resulting in defect of prevent normal implantation and the early placental development. So the drawback for the endometrial diagnosis for luteal phase defect on endometrial biopsy relies on microscopic appearance of the luteal phase endometrial development. However, implantation is associated with the numerous factors like steroid receptor, response to the endometrium, structural proteins, and cytokines receptor and phenocodes. I am not talking with this, but Professor B.N. Chakrabarty is there, and he is he's loving subject, and he is doing research for the more than few decades with this. Additionally, maturation may differ across the various stages, and prospective blind clinical trial demonstrate that endometrial biopsy is an imprecise tool for differentiating from fertile from infertile women. So the end of this endometrial biopsy is imprecise tool for particularly diagnosing the luteal phase defect in these cycles. So the endometrial biopsy at the ASRM says the abnormality of the endometrial maturation, the inadequate ovarian hormone secretion, intrinsic endometrial abnormality, gold standard to diagnose, though it is historically gold. However, prospective blind randomized RCT, that is a randomized control prospective, suggests that the endometrial biopsy is an imprecise tool for the differentiation women with luteal phase defect. So what are the other tools for diagnosis of endometrial receptivity, which is, I have already told, it is not the progesterone. Progesterone, estrogen prime, progesterone endometrium, how it works is also important for the luteal phase defect, because the histological evaluation of endometrium is imprecise. Many additional biochemical, morphological, and molecular markers of the endometrial function are proposed to assess. Potential markers for uterine receptivity, that is the cytokines, cell adhesions, LC. I do not have that much of this knowledge regarding this. All these are in the upcoming research. And Sir is there, Sir can say what are the things you may help with the endometrial receptivity and subsequent luteal phase defect and endometrial. If expression pattern of this protein proven to be predictive of endometrial If these are the helpful, then at this junction, whether with this receptivity strategies can be done, may help to diagnosis of the luteal phase defect by endometrial biopsy, otherwise not. However, no marker till date, endometrial receptivity no marker has been validated in a RC randomized control trial or multi-center or different trial, or to demonstrate the ability to distinguish from fertile domain from that of the infertile domain. So we have enough scope for the fertility specialist in point of view to have this study for this endometrial receptivity, what SAR is doing years after years. These are the sonographic criteria. It is the indirect criteria. If you have a good follicle, then you may suspect the luteal phase also good only from. These are the criteria. If there is follicle early rupture less than 70 millimeter only form follicle, premature luteinization, luteal cyst formation, absence of corpus luteum, and lack of endometrial echogenesis on the 7th postovulatory day is the sign of that phase. You may dealing with the presence of luteal phase defect. These are the fixture, not luteal phase, is the fixtures of the follicular phase. So you may have also investigation from the follicular phase. This is the sign of the ovulations. Now in 2012, the ASRM has what I have already told, but what they have revised in 2015, again the same things. That is, in summary, currently there is no reproducible pathophysiology relevant and clinically practical standard to diagnose luteal phase and distinguish from fertile from infertile women. The role of basal body temperature, urinary LH detection kit, these are the kit for the diagnosis of the ovulation, directly having a luteal phase defect or not. Luteal phase progesterone, that is the mid-luteal progesterone, particularly a 3 days mid-luteal progesterone and less than 30. Endometrial biopsy, still the historically gold, but have a scope if you can have the study for the endometrial receptivity, and other that have not been still not established. Performance on this test cannot be recommended routine basis, but you can do for the future research. So to conclude my talk, I really failed to diagnose properly the luteal phase defect, and each woman part, each cycle. There is currently no reproducible clinical practical standard to diagnose luteal phase defect, distinguish from fertile from the infertile woman. The role of luteal phase progesterone levels is also valuable for the 3 days progesterone estimation instead of single or instead of whole luteal phase progesterone level. Endometrial biopsy, which I've already told, and the other studies that the biopsy related the endometrial receptivity has not been fully stabilized, and performance cannot be done on routine basis. Furthermore, given a lack of clear correlation between the luteal phase defect by alternative definition and clinical relevant, no test can be diagnosed as the gold standard to recommend the particular patient for the diagnosis of luteal phase defect. However, there is a future research have so many scope for the diagnosis of the luteal phase defect on the basis of endometrial receptivity. Thank you all for your patience hearing. Thank you everybody.
Ram,
Yes,
can you hear me, Ram?
Yes, madam, I can hear you.
Thank you very much for your excellent talk. Really good. Thank you. Now, Sudhir.
Thank you, madam.
Hey, Sudhir, ye karo?
Unmute yourself.
Yes.
Thank you very much, Ram, for your beautiful presentation, elaborating everything. But just see, since the terminology came now for few decades back,
Yes.
luteal phase defect, still now, nothing is properly cleared, is not it?
Yes.
So I am asking whether ultrasonography, serial ultrasonography, along with your serum progesterone can give little earlier, some conclusion rather than endometrial biopsy. Endometrial is invasive procedure, very difficult to do regularly. So non-invasive, at least serial ultrasonography, as you said, folliculometry, and seeing the follicles with serial progesterone surgery.
Yes, I have told how to do the serial progesterone. It is not possible to enter luteal phase measurement of progesterone level. It is, as per ASRM, it is less than 80 cumulative, but it's not possible. For a single day mid-luteal progesterone is also not diagnosis, but the working formula is you can 5 to 9, the 3 consecutive 30, and ultrasonography not to diagnose luteal phase defect at the end of at the beginning of late. You have to diagnose from the earlier from the follicular phase and follow up the patient. If the patient have a good follicle followed by subsequently ovulation, then you may predict the patient having all
And
that.
with regular menstrual
With the
cycle.
history.
Regular
Yes,
menstrual cycle.
with the history taken.
At the end. Okay.
Yes.
Thank you, Ram,
Thank you.
for very much for the very
Thank you,
beautiful
Ram,
lecture.
for your wonderful deliberation and with a lot of message in it. And thanks to Dr. Sudhir Adhikari. Now, without wasting much time, so we are passing over to our next session. And here we have our chairpersons, Dr. Kalidas Bukshi. He's a consultant obstetrician and gynecologist and oncosurgeon. And past president of BOGS, president Indian Menopausal Society, president Isar Bengal chapter, organizing chairperson of IMS Con 2019, and together with Kalida, we have a very young chairperson this time, Dr. Shujoy Dashgupta.
Yes.
Shujoy, Shujoy is a consultant of reproductive medicine, Genome Fertility Center, Kolkata, secretary, website and bulletin committee of BOGS, and managing committee member of BOGS. So over to you, the chairpersons. And we have for the talk, we have none other than Dr. Ashis Kumar Mukhopadhyay. He needs no introduction, requesting the chairpersons to introduce Ashis.
Good afternoon. To start with, I must be very thankful to Gita Ganguly for allowing me to chair this very prestigious session. And the speaker is known as Dr. Ashis Kumar Mukherjee. The subject is how to manage the luteal phase defect. So diagnosis we have heard from Sabnam. What is luteal phase? We have heard from Sabnam, and the diagnostic procedures we have heard from Ramprasad, but which is not very sure how to diagnose and what are the criteria of diagnosis. When the diagnosis is not very sure, let us find out how to manage this undiagnosed luteal phase defect from Professor Ashis Kumar Mukherjee. Ashis, floor is yours.
Ashis,
thank you. Can you hear
one
me?
thing I want to say.
Introduction of Ashis.
Welcome to the young Shujoy. Where is Shujoy?
Shujoy.
Yes, ma'am. Yes, ma'am. Yes, ma'am. I'm here, ma'am.
Thank you very much for coming. Thank you, Kalidas Bukshi and Ashis. It's a very important subject. Everybody is waiting to hear from you. Thank you.
I must say that Ashis is the past president of BOGS,
yes,
and at present the principal of Chittaranjan Shiva Shraddhan, and also has past vice president of Foxy. So, yes, Ashis.
Intentionally, I didn't say because Ashis is known to everybody, our beloved Ashis. And
yes.
he's now in a very prestigious position of the principal and professor of our Chittaranjan Shiva Shraddhan, from which I have learned the operation. And he's the past president of Bengal Obstetric Society. Everybody knows it. But now, which is very important, which one should be knowing, that she is the Medical Education Committee Chairperson, Foxy ex-chairperson. So Ashis, please start your subject.
First of all, my respectful regards to our Gitadi. She's such a lovely lady. She invites me every time, and I cannot say no. Simply not possible. And also my respectful regards, pranam to a huge personality, almost a god to us, that is Professor B.N. Chakravarty. And my senior, Kalidas Bukshi, Dr. Kalidas Bukshi, and Shujoy, my dear brother. All of you I am meeting, and it gives me extreme pleasure in interacting with them on a subject which is probably the toughest subject for any gynecologist or any infertility specialist. Now, I liked the one comment from Kalida. He said that the condition whose diagnosis is not certain, how can he manage? Let us see. Kalida, for your kind information, half of the problems of the country are being managed without diagnosis. So I believe we have to do something. We have to do something about this problem also. But I believe that the problem is really, really difficult. because there are no yardsticks or parameters to measure the success of the treatment. That is the reason why we're worried about. And I feel honored, but at the same time very scared to talk in front of Professor B.N. Chakravarty, whose primary research is now luteal phase defect. Coming to the terminology, madam, my humble submission is that I dislike the term defect very much. So for some time, the terminology was corpus luteum insufficiency, but I don't know why this terminology has come back. So I have retained this terminology of luteal phase defect. But the ideal terminology would have been the corpus luteum insufficiency. Anyhow, who are the suffering population? 3 to 20% of the subfertile patients, 5 to 60%, higher percentage of women experiencing recurrent pregnancy loss. However, data shows that 6 to 10% of women who are normally fertile, they also demonstrate an inadequate luteal phase. And this is the reason why many of the gynecologists do not believe in the concept of luteal phase defect. And that is why they say, what is the point of discussing something which doesn't exist in reality? But however, the infertility specialists are facing it day in and day out, and therefore we have to do some justice to this problem. Definition has been adequately dealt with, so I'm not going into that. There is a qualitative definition and there is a quantitative definition as well in terms of the cycle length. So all have been dealt with properly. But whatever the definition is, it is very difficult to define it comprehensively like other medical condition. So I won't try that. This has been also been dealt with the clinical and biochemical luteal phase defect. Clinical means when the luteal phase is less than 10 days duration. Some people say less than 9 days. Some people say less than 11 days. But overall, less than 10 days is well accepted. So this is known as clinical LPD. And when the serum progesterone level is less than 5 nanogram per ml, we call it biochemical luteal phase defect, biochemical LPD. Histopathological LPD, actually not much used the terminology, but that has been described by our first speaker. Almost all the women with a clinical LPD of less than 10 days also had a mid-luteal serum progesterone value of less than 10 nanogram per ml. So this is a good association, and therefore this can be a tool for future clinical research assessment of LPD. But in reality, the value of progesterone, which is critical value, is much less, which is less than 3 nanogram per ml. Now, American Society of Reproductive Medicine, the Committee Opinion 2019, which was published in 2021, they said, although progesterone is important for the process of implantation and early embryonic development, LPD has not been proven to be an independent entity causing infertility or recurrent pregnancy loss. There's a huge lot of controversy which exists regarding the multiple proposed measures for diagnosing LPD and assuming it can be diagnosed accurately, whether treatment improves or outcome or not, that is also yet to be seen. So we are in double dilemma. I think Ram has described this very well, 2 mechanisms proposed for the development of LPD, that is pathophysiology. So I will skip these slides. But what is important here is the description of the underlying conditions, which I think the first Sabnam has dealt with is very comprehensively. So here is the list. Everyone knows about the list these days. The conditions that have been associated with luteal phase defect, and they are a huge lot of things, and they need to be addressed first. That is the most important thing. So I will come to that a bit later. But what is important here, what we usually ignore, is the uterine abnormalities, like a myoma or a uterine septum or an endometritis. They can be responsible for poor secretory changes in the endometrium. And hypocholesterolemia is another association, substrate responsible for initiation of the steroid pathway, which is defective, and that is why that results in the corpus luteum insufficiency. Now, Ram has showed you this slide. I think in 2012, ASRM took a call, the practice committee of the ASRM said that there is no reproducible, physiologically relevant, and clinically practical standard to diagnose LPD or distinguish fertile from infertile women. He showed the slide in 2015, but he didn't show the slide of 2021, which is published in 2021 June, which also says the same thing. That means even today, in 9 years, nothing has changed. So diagnosis of LPD is still a matter of conjecture. So I think I will skip the diagnosis of LPD because adequately it has been dealt with. And there are many things which are in detail described, and including the endometrial biopsy, because if you arrange them in the order of increasing invasiveness, all the investigations have been adequately explained, like the menstrual cycle examination, the basal body temperature, then the single or multiple serum progesterone level, etc., and finally the endometrial biopsy. In the end, even then, we could not diagnose the luteal phase defect. Ram was talking also about this, about the integrated luteal phase progesterone value. The reason being that single progesterone value may not be adequate or may not be representative of the ovulation, and therefore, corpus luteum adequacy, and therefore integrated value were taken. And taking 10 values is very difficult. And so it was proposed that you take 3 daily luteal progesterone values between the days 5 to 9. It can be between 6, 7, 8, or it can be 5, 7, 9, or something like that. And you make this thing average of them. And if it totals less than 30 nanogram per ml, it is diagnostic. It is more or less diagnostic of luteal phase deficiency. But none has been clinically validated and may be clinically impractical also. So in the workup of infertility patients or in recurrent pregnancy loss for this corpus luteum insufficiency, I'd rather say that there is a scope of a lot of research in the future, which is going on at the moment. There is something called progesterone endometrial protein, or PEP, which is still inconclusive and in the research stage. There are studies going on integrins, growth factors, and cytokines, which I think Sabnam has mentioned. And also imaging studies have been adequately dealt with by Dr. Ramprasad Dey. So come to the treatment, let us. Now you will agree with me that this is really a tricky situation. Why it is tricky? Because how to treat a disease condition that cannot be accurately diagnosed, the original question raised by Kalida. And therefore treatment has to be empirical. So studies have used improvements in surrogate markers to show treatment effect, like endometrial biopsy, progesterone level. But what happened at the end of all attempts to link these surrogate outcomes to fertility outcomes have been unsuccessful. And here lies the importance of treating underlying conditions. So the first approach to the treatment of a patient with suspected or reasonably confirmed luteal phase defect should be having 2 strategies. 1, improving the follicular development, and 2, supplementing progesterone. I'll come to that one by one. Underlying condition, treating the underlying condition is extremely important, of which 2 are very, very handy to us. One is the hypothyroidism, and another is the hyperprolactinemia. So that everybody will do. And this is extremely important to diagnose pre-existing hypothyroidism or hyperprolactinemia before you proceed on any treatment of progesterone replacement therapy or something like that. Clomiphene citrate and or HMG or FSH, the idea is it enhances follicular development and thus increases the luteal phase progesterone levels. Good idea, the concept is good. Idea is that when you put importance on the foundation of the house becomes okay, that's good. But then it doesn't work out that way. And many factors are there between these 2 things. And as I said, treatment of uterine abnormalities like myomas or uterine septa, endometritis, etc. need to be treated first. And correction of hypocholesterolemia is also very, very important. Coming to the ovarian stimulation, the use of agents to stimulate the ovaries may improve the fertility of subfertile women because of physiologic continuity. Because the same thing, there's a follicle which was there is developing into a corpus luteum. So if you can develop the follicle well, then ovulation induction should be able to, theoretically to make a good corpus luteum. But unfortunately, ovulation induction has not been demonstrated to improve the LPD. So that attempt also has failed more or less. So therefore, there lies the question of the luteal phase support or LPS. This is a very, very controversial issue, I know, but there is no other way. You cannot escape from the luteal phase support. And when the first hormone about the luteal phase support is progesterone. It's an essential hormone during the first trimester of pregnancy. Everyone knows that. Should be started in the luteal phase and continued until 7 to 8 weeks gestation. If you are having one pickup today, between today and day 3, you should start the progesterone supplementation and continue it at least till 7 to 8 week gestation. Many people take it further, and it is not necessary to proceed further, but many people do that. But before starting this, you must have a disclaimer, and you must talk to the patient husband and relative that there are many preparations like oral, vaginal, intramuscular routes, but there is no evidence that the progesterone is beneficial for fertility in natural cycles. No RCTs have been there which investigates the progesterone, and progesterone supplementation for recurrent pregnancy losses. There are studies, RCTs are there, but they are conflicting and may not necessarily be reflective of the patients with LPD. So let us come back to the effect of progesterone on the effect of progesterone on the endometrium. I think some of it has been dealt with, but a detailed discussion on that is necessary because we need to understand progesterone properly before identifying the progesterone, which one to take. It inhibits the E receptors, it decreases the mitotic activities, promotes the E1 synthesis. And remember, the estrone has got lesser affinity, and that is why it is less active estrogen, and thereby it nulls the effect of the estrogen on the endometrium. It promotes endometrial protein synthesis, or PEP, and transforms the fibroblasts to the decidual cells, enhances the pinopod activity, and induces secretory changes in the endometrium. But more importantly, it keeps the stroma in synchrony. Otherwise, if there is a glandular and stromal disharmony, which is Professor B.N. Chakravarty's favorite topic, then everything becomes in disarray and everything is lost. So progesterone keeps the stroma in synchrony with the glands, and that's a huge thing to do by the progesterone. So let us discuss why progesterone is so special. It boosts the maternal immune response also. This is a very important topic and favorite topic of Professor Chakravarty. It acts as an immunomodulator. And then the placental cells and the decidual CD56 plus cells, they synthesize progesterone-induced blocking factor. That is also a very important thing in presence of sufficient progesterone. So to produce PIBF, you need adequate amount of progesterone. And this PIBF will affect P cells and induces an increased production of asymmetric non-cytotoxic antibodies. PIBF also alters the profile of cytokine secretion, and that increases the production of the non-inflammatory, non-cytotoxic interleukins, good cytokines like interleukin 3, interleukin 4, interleukin 10. So 3, 4, and 10, these are good cytokines, and a reduction in the inflammatory cytotoxic cytokines like interferon, the T1 necrosis factor, and in interleukin 2. So PIBF induces a type 1 to type 2 cytokine shift. So that is the progesterone is so special. If you put in more progesterone, more PIBF will be produced, and that way it will help the cytokine balance to be restored towards the beneficial side, towards the pregnancy retaining side, and taking it away from the abortion side. So that is a very important role of progesterone. Coming to the another drug that is which is hugely marketed, that is micronized progesterone. That is it is a safe drug. It is available in many forms, in different doses, gel form. Identical structure should not be called natural. Nothing is natural in pharmaceutical industry. Everything is manufactured in the laboratory, but we should call it micronized progesterone instead of calling a natural progesterone. The size is small, less than 10 microns, and therefore it has got increased affinity and work, approved and widely used globally across the globe, including India. The second drug is dydrogesterone, retroprogesterone. That's a mirror image of or stereoisomer of micronized progesterone, and therefore it is very effective because the structural similarity. The conformation is induced by exposing progesterone to ultraviolet light, has high affinity for progesterone receptors, highly bioavailable after oral intake. That's another advantage because Indian women love taking oral preparations. Available as 10 milligram tablets. It was first introduced in 1961, and it is available widely in more than 100 countries. So this is a very good preparation if you want to have a oral medication with some advantages. I think the rest of the things will be talked about by Dr. Gautam Kasturi. I think he's following me, and he'll be talking about dydrogesterone, leaving it to him. Now let us come back to the other supplementation which we have done. And here I think we get a lot of data from the ESHRE, the European Society version, because ASRM is silent on these issues. But everybody has talked about the other supplementation. Just look at them, what they have written. The Cochrane meta-analysis reported no difference in live birth or ongoing pregnancy rate or OHSS between progesterone with estradiol supplementation and progesterone alone. The addition of estradiol to progesterone for luteal phase support is probably not recommended. I think we will get this support from the Cochrane database later also. I will show you that. What about HCG? There's a Cochrane meta-analysis also found a higher live birth ongoing pregnancy rate with HCG. So the live birth rate or ongoing pregnancy rate is higher with HCG. But the problem is the OHSS rate is increased with HCG for luteal phase support. Now, when this is when the HCG was compared with the placebo, the OHSS rate was increased. But when compared to progesterone, HCG for luteal phase support or supplementation of progesterone with HCG did not have a beneficial effect on live birth or ongoing pregnancy rate also. So compared to placebo, it works well, but compared to progesterone, it doesn't work that well. And on top of that, it has the problem of ovarian hyperstimulation syndrome. So now you can see that why it is not useful. The other drugs, there are 3 drugs which are still under research and 3 preparations which are being researched actively, very vehemently are. One is GnRH agonist bolus dose, in addition to progesterone for luteal phase support. In HCG triggered cycles, it can only be used in the context of a clinical trial. All these 3 drugs can be used as a research molecule and not put to the clinical usage. Second is a repeated GnRH agonist injection, and the third is the addition of LH injection. So nothing has come up till date. So we have to look for the clinical evidence that is available for the luteal phase support. You can look at this Cochrane database, which shows that both progesterone and HCG, this was in 2015, both progesterone and HCG during the luteal phase are associated with higher rates of live birth or ongoing pregnancy than placebo. That's what I said right now. The addition of GnRH agonists to progesterone is associated with an improvement in pregnancy outcomes. Research is going on. OHSS rates are increased with HCG compared to placebo. The addition of estrogen does not seem to improve outcomes. The route of progesterone administration is not associated with an improvement in outcome. That's a very important statement. Now about the other routes of progesterone, that is for the intramuscular route of use, that is also has been shown to be effective in 2015. And therefore, there is a lot of controversy about which route to be used in cases of progesterone if we use at all. Of course, we have to use progesterone only, nothing else we can use at the moment. Estrogen supplementation to progesterone is not very useful. We have already discussed that. And this was also discussed by another study, and they said that higher clinical pregnancy rate, although you get, but it is not sustained, and therefore you should not go for that estrogen supplementation. So in summary and conclusions, if you want to have take-home messages from this talk, you can see that after a half an hour or more than that discussion, we could not find how to diagnose this condition, how to investigate this condition, and how to treat this condition. That is the problem of this luteal phase insufficiency. So there is no diagnostic test for LPD. Endometrial biopsies are historical now, not recommended. No treatment for LPD has been shown to improve pregnancy in natural cycle, unstimulated cycle. So now the treatment is reserved only in the ART cycles. And the progesterone supplementation needed in ART cycle, that is beyond question now. We have to go for that. The correct approach of the treatment of LPD is treat the underlying condition first, like hypothyroidism, hyperprolactinemia, myoma uterus, etc., obesity, PCOS, and then go for the ovulation induction, other things. Luteal support after ART procedures with progesterone or HCG improves pregnancy outcome, but HCG increases the risk of OHSS, so don't use HCG. Exogenous progesterone is the primary agent for luteal support during ART treatment. However, the best delivery method, the protocol, and the formulation best way is not yet known. Vaginal or intramuscular progesterone seem to be equivalent in terms of pregnancy outcomes after ART treatment. And among different routes of administration, vaginal, oral, and rectal, there are no statistically significant differences. More research is needed. So if you want to take some few messages home, just there are a lot of scopes of research Professor Chakravarty is doing, and I think all infertility doctors should be involved in the research. And the research to find out the basic things. If the isolated LPD is a clinical entity that leads to infertility, that needs to be determined first, because after that, a lot of things will come out. And we were talking about the combined testing, that is the luteal progesterone measurement and the luteal phase length. That means combining these two, whether that can be applicable to clinical situation, and you can identify a subgroup of patients in which poorer reproductive outcomes occurs, and whether the treatment improves the condition. That research is also pending, and till then, the management is essentially empirical with all its associated plus and minus points. So I'm sorry, Didi, right now said he failed to diagnose. I also failed to treat the condition. And I think that people are going to fail for years to come unless and until proper and designated research comes into play. Thank you very much all for your patient hearing. Thank you.
Thank you, Ashish. Thank you. You have explained the pitfalls of the diagnosis and also management. Though it is empirical, we are all doing empirical treatment, no doubt. Thank you very much. Time is very short. Let us invite the next speaker.
No, one thing, there is no Mausumi.
Yes, yes.
You call Sir, whether he will give some comment.
Yes.
Ashish is very nicely have said all these things.
So
Sir
there
is
are many pitfalls and there are many gray areas which is not clear to us. So we have with us our teacher of teachers, Professor Chakrabarty, sir. Sir, we are waiting for your expert comments on this.
Is he there?
So we are now passing over to our, now I'm asking everybody, if you have any queries, kindly put it up in the QA box, and that will be taken up during the interaction with all our expert faculties. Now we are passing over to our next session. May I call upon Dr. Avinash Chandra Rai, the Vice President of BOGS, and Dr. Avinash Chandra Rai. Yes, and he is the visiting consultant of Amri Bellevue Chanak Hospital, and winner of Foxy Best Paper Award, and author of many publication and books. So our another chairperson here with us today is Dr. Ratna Chakravarty. She needs no introduction. Director, MAGS Medical and Research Center Private Limited, Chairperson, National Advocacy Committee, IMS, Past President, Indian Menopause Society, Vice President, National IMA Women's Wing, Chairperson, Women's Cell, Indian Medical Association, Bengal State Chapter, State Coordinator of Mission Pink Health, Founder Secretary of URGO, and NGO, and she worked in many NGOs. So over to the chairpersons for introducing their eminent speaker, Dr. Gautam Khastagir.
At the onset, I thank our beloved Gita Di for your organizing such a nice and wonderful program of RN Ganguly Foundation. And Gita Di, thank you once again for giving me the opportunity to chair this important session. And now I am to introduce Dr. Gautam Khastagir, who needs no introduction. He is a well-known face in the field of obstetrics and gynecology, particularly in the arena of infertility and IVF in India. Your topic is Gautam, role of dydrogesterone in gynecology. And another one thing, to tell something about Gautam, the recipient of Wellbeing Research Grant of RCOG London, published many research papers in infertility, hormone therapy, and endoscopic surgery in international journal, RCOG accreditation, subspecialty training in reproductive medicine and surgery, and level 3 endoscopic surgery, medical director of birth and advanced. However, Gautam, the floor is yours.
Thank
Gautam,
you.
are you there?
Gautam?
Can you hear me?
Gautam, welcome very much.
Thank you.
And we are all waiting for your lectures.
No, thank you. Thank you very much. At the outset, we have said it so many times, Professor Gita Ganguly Mukherjee is like a magnet. She can attract everyone in West Bengal, in India, and even from abroad. And she's continuing to organize this type of meetings for last so many years, for decades. but now she's doing it on webinar. Now, whenever Dr. Ganguly Mukherjee requests us, none of us can say no. And why would we say? Because she is organizing such a good meetings. Now, when she asked me to talk on this, I said, I'll just be very frank with you. I said, the dydrogesterone and infertility, it's old wine in a new bottle. And Ashis has wonderfully done that job. And there is lots of new research. Before that, Dr. Ramprasad and the previous speakers have covered it nicely. But as an infertility specialist, first of all, I'm an obstetrician and gynecologist. I felt that while seeing infertility patients, we often come across gynecological problems. So they are like two sides of a coin. So sometimes we need to think whether this molecule is suitable for gynecological treatment or not. And this has become now my main interest. I've given this talk in several conferences and webinars now. So what I'm trying to say in next few minutes is perhaps we have found an ideal progesterone and which may bring breakthrough in the gynecological treatment. Now, just okay. Now, in gynecology clinic, we know there are different menstrual disorders: dysmenorrhea, severe dysmenorrhea, premenstrual syndrome, which we often ignore in this part of the world, but in the Western world, premenstrual syndrome is a big problem, and they usually come to the gynecologist, sometimes the psychiatrist. Abnormal uterine bleeding like menorrhagia, polymenorrhea. Without going into statistics to this learned audience, I would say it's very common problem, so much so that perhaps even a couple of years back, more than 50% women underwent hysterectomy within 5 years of their symptoms. So when they develop the symptom within 5 years, they had to have a hysterectomy. Perhaps that is not the case now because of many good medical therapy and other surgeries which can avoid hysterectomy. Now, we usually treat this problem with progesterone. There are different types of progesterone: 19-not-testosterone, 17-hydroxyprogesterone, micronized progesterone, and dydrogesterone. Now, on the left-hand side, I put different pharmacological activity like blocking out of ovulation, masculinization of the fetus, thermogenicity, feeling hot while taking this medicine, androgenic effect on the person, on the individual, on that female. So if we compare the different type of progesterone we have been using, most of the progesterone, they have some limitation, including even micronized progesterone. If you take micronized progesterone throughout the month, it will suppress ovulation and it will have thermogenic effect. If you are giving hydroxyprogesterone, it will have, in addition to that androgenic effect, adrenal atrophy, clotting problem, and 19-not-testosterone, although it can control the bleeding very well, it can control the menstrual disorders very well, it has many side effects. So time has come for us to, particularly in the current medico-legal scenario, to offer a progesterone which is even better than the natural, better than the best. So it's a tailor-made, like Levial is a tailor-made estrogen, dydrogesterone is a tailor-made progesterone. Now, I wouldn't repeat this because you have heard from Ashis what are the natures of, how it is a retroprogesterone. It is very similar to natural. What we have to remember, it is high bioavailability and safety. The selectivity of the progesterone receptor is 20-folds more. But most importantly, after working with Professor John Stark for more than 7-8 years, he used to say the progesterone is the bad guy. So all joto ghosh nando ghosh. He used to say all problem is because of progesterone. So estrogen is the good guy, progesterone is the bad guy. So we have to find a progesterone which is not so bad. So all these things, mood swing, weight gain, depression, premenstrual syndrome, clotting problem, carbohydrate, lipid, everything is because of progesterone. Now, if we think about progesterone, it not only has usual secretory change and desidualization, it also has other mechanism of action. It represses ROS formation. It also modulates nitric oxide synthesis and expression activity in the endometrium. it modulates, you have heard from Ashis, it modulates cellular mitotic activity process, modulate action to prevent recurrent miscarriage, may have immense benefit in gynecological issues as well. Okay. Now, the next is there are special pharmacological features which are really superior. It is designed to be orally active. It is designed to be well tolerated. It is designed to be safe and is designed to be convenient. Now, why convenient? It can be used orally, not vaginally. Patients can use long term. It is really safe. It doesn't have adverse effect on the carbohydrate lipid mechanism, on the liver, on the endometrium. Now, it is orally active and it is well tolerated, very little side effect. Now, proof of the pudding is in eating. Let's see some of the evidence from the paper. Now, this paper looked at menstrual cycle normalization with dydrogesterone. And they saw in about 99% of the patient, after taking dydrogesterone, the periods become regular. And it continued regular menstrual cycle even after stopping the therapy. So effect is not short-term, effect is actually long-term. And there is a direct relationship between the duration of therapy and long-term efficacy. So if you use it for 1 year, maybe you get effect for 2 years. If you use it for 5 years, you get it for 10 years. Again, it brings analogy with hormone therapy of estrogen. The satisfaction rate is very high, more than 90%. Now, if you see the same paper in a graphical fashion, they had two groups of patients. One group, they were using it just for 3 cycles, and other group, they were using it for 3 to 6 cycles. One is in violet, and violet is 6 months, and blue is in 3 months. And what they saw is number of cycles of regular menstrual cycle achieved during follow-up. So even after follow-up, nearly 80% of the patients were normal. So it is not like as long as you take your well, as soon as you stop, it's abnormal. That is not true with dydrogesterone. Now, in addition to the irregular menstruation, they also looked at the intensity of pain and intensity of anxiety. Anxiety means, menstrual problem bring lots of anxiety. So baseline, end of estrogen therapy, and end of follow-up. So from baseline, intensity of pain diminished significantly, intensity of anxiety diminished significantly. But what is very, very appealing, that even after stopping the therapy, during follow-up, this benefit continued. So there must be some form of mechanism which is regularizing the physiological action, physiological system of hypothalamic or pituitary ovarian axis, or maybe locally acting on the endometrium. Now, what is its effectiveness in regularization of menstrual cycle? In another study, what we found that again menstrual cycle was regularized and it relieved the menstrual pain. It was effective in polymenorrhea as well as in oligomenorrhea, and it was safe in patients of all age group. This is very important. If you have a patient who is having puberty menorrhagia, sometimes you do not want to give 19-not testosterone because it's going to give you side effect. If you have a patient who is in the 40s, you may hesitate to give a progesterone which has got adverse effect on the liver or adverse effect on the clotting. So this is a progesterone which will be safe throughout the age group. In this study, they also looked at the patient satisfaction, and patient satisfaction was fantastic. More than 90% patients were very happy with this. And they reported they are normal and not ill at all after taking this treatment. In another study, they looked at different menstrual problems: menorrhagia, polymenorrhea, metrorrhagia, menometrorrhagia, polymenorrhea, and menorrhagia. And what they found that more than 80% in majority, except menometrorrhagia, 66%, patients had significant relief of symptom when they're taking it 10 milligram per day. Now, duration of therapy, I will come to you just in a little while. Now, our good friend Nicolas Pane, who is a big authority now in International Menopause Society, Ratna knows him very well. He came to Kolkata. He did a study looking at dydrogesterone in secondary amenorrhea. So patients who are not having period, what we do? We give a withdrawal bleeding. we give a withdrawal bleeding. If there is estrogen with progesterone, they'll have withdrawal bleeding. Now, you cannot give it for just one cycle. You have to give it for several cycles. And what he found, what efficacy was very good. Interestingly, if some patients also responded with placebo, that means, they started their progesterone production on their own. Now, in this study, and Nicholas also showed that by comparing this, there was improvement in pain, improvement in the pain score. So regularity of the menstrual cycle, as well as the pain relief was significant. And the difference between placebo and dydrogesterone wasn't much at the beginning, but as they continued, dydrogesterone was very effective in giving pain relief as well as regular period in patients who are having secondary amenorrhea. Now, another paper looked at efficacy of dydrogesterone in premenstrual syndrome. Now, premenstrual syndrome is a big issue in the Western world. Professor Studd had a psychoneuroendocrine clinic. He didn't call it PMS clinic. He used to call it psychoneuroendocrine clinic, where patients with depression, with irritability, with anxiety, and different physical symptoms, which used to go according to the menstrual cycle. And some patients used to come even after hysterectomy, and he used to call it cyclical ovarian syndrome. So if you remove someone's uterus and leave the ovaries, they continue to get this type of symptoms. So there is no menstruation, so you cannot call it premenstrual syndrome. So cyclical ovarian syndrome. Now, we have tried different medicines for this. Now, what was seen, that contraceptive pill has some benefit. You can give estrogen therapy along with cyclical progesterone. In very severe cases, you can give GnRH analog. You can use, some other medicines, which is non-hormonal medicines. Now, dydrogesterone has not been tried so much, except few studies like this one. And this was a double-blind randomized placebo-controlled study. They used 10 milligram 2 times daily from day 12 to day 28, something like that. And what they found was 52% patient with dydrogesterone and 44% with placebo improved. And this is something with PMS. This is tender loving care. If you listen to the patients, if you counsel the patient, if you support them, if you give them a positive message, some of them would even respond with placebo. So overall clinical improvement was not in general significantly improved, but what was seen that those patients who are complaining of reduced libido, irritability, and headache, perhaps dydrogesterone has an important role to play. And this is what is shown graphically. In red, we have dydrogesterone, and in blue, we have placebo. And it was seen there was significant improvement with oral dydrogesterone with these particular symptoms. So in general, effect is not that statistically significant, but definitely if we do more studies, perhaps different doses, then we may see it will be effective in premenstrual syndrome. So it is just like one of those things where you cannot prescribe estrogen, oral contraceptive pill, or estrogen patient is not keen, then dydrogesterone will be effective in premenstrual syndrome. And this study again showing graphically how, with the table, how it was changing between first, second, and third cycle. None effect, some effect, moderate effect, good effect. And if you look down below, it is not statistically significant, but differences were there. Now, finally, dydrogesterone in endometriosis. In endometriosis, we have used different products. Progesterone is not so effective because, first of all, it gives breakthrough bleeding. You cannot take progesterone for long term without breakthrough bleeding, and there are many side effects. With dydrogesterone, there is relief of pain, regression of the lesion, and improved pregnancy rate. It makes the endometrium, ectopic endometrium, atrophy, and it will inhibit development of the new endometrium, but it would not suppress normal intrauterine endometrium. So this is the unique effect. So dydrogesterone has got no adverse effect inside the uterus, but in all ectopic area, it works like that. Therefore, it is very suitable for those patients who have got abnormal uterine bleeding, but they would also like to conceive. Now, perhaps 19-nortestosterone cannot be given. Even medroxyprogesterone we give, they do get pregnant. Many a time we ask them to continue the pregnancy, but we have this hesitation whether it's going to have any teratogenic effect or not. With dydrogesterone, that is not there. Now, danazole and GnRH analog obviously cannot be given to those patients who are planning for pregnancy. So with dydrogesterone, there will be symptom recurrence, just like any other endometriosis therapy, after 6 months, 50% of them, this patient will come back with the symptom. That is not surprising. And this is the molecular mechanism of how dydrogesterone works in endometriosis and adenomyosis. So it is actually working in the cellular level, in the molecular level, like TNA alpha, interleukin, and growth factors. All these things are suppressed. The neogenesis is suppressed. So it is not just by suppressing the menstruation. There are other mechanisms of action of dydrogesterone in suppressing endometriosis or treating endometriosis. Now, when we give progesterone in infertility, we know in endometriosis, we know it is not suitable for infertility because progesterone itself reduces the frequency and increases the amplitude of pulsatile release of GnRH. It lowers FSH and LH secretion, suppression of ovarian steroidogenesis and suppression of ovulation. There will be decidual transformation resulting in necrosis and resorption of endometrium. There is low serum estradiol level leading to breakthrough bleeding, and there are androgenic side effects. But the exception is dydrogesterone. So if we want to use progesterone for endometriosis and infertility, definitely dydrogesterone is the drug of choice. Now, it has been proven by this couple of studies. This study was open label, dydrogesterone treatment of dysmenorrhea. They use dydrogesterone for 21 days, day 5 to day 25. There was no suppression of ovulation. They had regular menstruation, reduced amount and duration of flow. And they also looked at other different parameters like total dysmenorrhea score, infertility score, visual analog scale pain score, analgesic usage score. And they have shown that after using it as early as from second cycle, there was significant improvement, and that improvement continued as long as they used it. Now, this is specifically menstruation related symptom, abdominal pain, low back pain, headache, nausea, vomiting. As you can see, it continued, the improvement continued. There was significant improvement from the first cycle, and it all continued. Now, finally, this paper from our own country, our Prakash Trivedi, Kamla Selvaraj, Promothesh Da, Dr. Sharoj Srivastava, and Sonia Malik did this study. This was published long back in 2007, nearly 14 years back. It was an open prospective multi-center study. Those patients who were having laparoscopic treatment for endometriosis, they were put on dydrogesterone after the surgery. And again, they gave it 10 to 20 milligram. Perhaps we need to have a uniformity. Some use 10, some use 20, depending upon the severity, and they used it for 21 days. What they found, there was significant 95, 87, 85% diminution of pelvic pain, dysmenorrhea, and dyspareunia, and the amount of duration of menstrual bleeding diminished significantly down to 10 to 12%. And during this period, 20% of their patients, 1 in 5 actually conceived, and 20% patients say they were cured, and 75% patients say their symptoms improved. And if you look at the patient satisfaction and physician satisfaction, then it was 74% satisfied patients and 70% satisfied physician. And this is what again shown graphically. So what we see is excellent satisfaction in about 22% patient and 13% of the physician, whereas good satisfaction was good in about around 52 to 56%. So finally, what we say, there have been several studies looking at dydrogesterone and endometriosis. Some are double-blind, some are open prospective, and they use dydrogesterone in different doses. The first study used dydrogesterone 40 to 60 milligram for 12 days. Now, 40 to 60 milligram is very high dose and it's expensive. Many a time we cannot use it. Now, different companies are bringing dydrogesterone, so hopefully it will be cheaper now. The second study used for basically 10 milligram a day, again roughly for 20 days. Third study used 10 or 20 milligram roughly for 20 days. The fourth study used it, initially they used it 10 milligram a day between day 5 to day 15, and then 20 milligram a day, day 16 to day 25. So there has been a sort of, pick and choose method. No one uniformly decided on what should be the ideal one. Now, time has come for us to do studies, sort of prospective studies maybe dose control studies, dose assessment studies, what will be the right effective dose, what will be the right effective duration. Now, when we are using dydrogesterone for luteal phase support, we are giving it from day 16 to day 25, roughly the luteal phase, maybe up to 10 to 14 days. But in gynecology practice, we have to use it for a longer duration. If it is for regularization of the menstruation, just the progesterone in the luteal phase 10 to 14 days is okay. But in order to treat pain in endometriosis, we have to give it for a longer duration, like 20 to 25 days. So ladies and gentlemen, my take-home message will be, we can use dydrogesterone for menstrual irregularities. We use it maybe from day 11 to day 25 for 14 days. Maybe we can use it for 20 days. Primary and secondary dysmenorrhea, again for 20 days. For dysfunctional uterine bleeding, roughly for 20 days. PMS, they have used it for 14 days, day 11 to day 25. Day 11 to day 25 is roughly 15 days, sorry. Secondary amenorrhea, again for 15 days. Now the issue is what is convenient for the patient, what is cost effective for the patient, and what is finally curing the illness. Now, as regards endometriosis, perhaps in endometriosis, we may have to use a higher dose in some patient, 10 milligram twice or thrice daily, again between day 5 to day 25. Now, I always think about it, the medicine comes in a packet of 10. Now, if we use 21 days, sometimes they have to buy another packet. So instead of 21 days, we can reduce it down to 20 days just to make it suitable for them to buy. And all these studies have shown that it works very nicely. I'm not saying this is the only treatment, this is the best treatment, but we have to keep in mind in those patients where we cannot use the other therapies like oral contraceptive pill, GnRH analog, danazol, norethistérone. In those cases, particularly in young girls, particularly in elderly women, premenopausal, perimenopausal women, this will be a good choice. Even in HRT, in postmenopausal patient, if you want to continue estrogen and progesterone with estrogen, dydrogesterone will be a good choice. So thank you very much. Thank you. Thanks for your patient hearing. I'll be happy to answer any questions if there are any.
That will be at the end of the session.
Thank you, Gautam, for your excellent deliberation. Now, I would just like to tell a few things that you have mentioned, because Dr. B.N. Chakravarty is here, who has used it and has done extensive research on it. You have discussed about Dr. John Starr, and you mentioned Panay as well. I would like to mention one more person who had done many works on it and then presented in probably 1999 AICOG conference, the oration, Professor Rajan. So Professor Rajan talked on this, and the first time I came to know that it does not inhibit ovulation. So in endometriosis cases, you can go on giving it without causing any problem in woman who wants to conceive. And also, he first time came out with a theory of immunomodulation, so that when there is a chances of recurrent abortions or spontaneous abortions, let's support not with natural progesterone, but with dydrogesterone. So that was a comeback of dydrogesterone the second time in the field. And as you know, as you have mentioned also, progesterone was discovered in 1929. And the dydrogesterone was discovered in 1950. So there was a long gap during which we were just wondering what to use instead of giving painful injections. And from 1961 till date, which means 60 years, it's an amazing molecule because every year something new are coming up. And as you discussed that after laparoscopy, you go on using dydrogesterone, giving excellent result. I have 2 cases who had T8 and BSO for endometriosis. When the clearance was done, even then they developed some small cysts. So in these cases, medroxy may be given in some time, but these patients, they were not tolerating progestogens. So they were given this dydrogesterone and gave excellent result. So I don't know how many more characteristics and good effects will come out of it. So let's use it and we will get more and more out of it. Thank you very much, Gautam. because you
Thank
have
you, Didi.
discussed almost everything on this. You can't finish it. I know that.
Thank you. It's so nice to have Dr. Budidi as my chairperson, because when I was intern, I started my gynecology journey with Didi being my house staff in Eden Hospital, and it brings all those nice memories. She has always been like my একদম ছোটবেলার থেকে দিদি হাত ধরে এই পর্যন্ত নিয়ে চলে এসেছেন একদম। But one request to Gita Di, perhaps Gita Di can only do it. Now, so many companies are bringing dydrogesterone, but they are not reducing the price. তা আপনি ওদের একটু কান মুলে দিন দিদি, ওদের একটু কান মুলে বলুন যে ওষুধের দাম কমাতে হবে, ওষুধের দাম না কমালে হবে না, এত লোভী হলে হবে না।
No, but one thing,
এতদিন পর্যন্ত কি একটা কোম্পানির হাতে ছিল, আমরা দেদার লিখতে পারবো যদি দামটা ওরা কমায়।
না এটা কমাচ্ছে তো ওরা।
না আপনার শাসন দরকার, আপনাকে বলতেই হবে বেশি করে।
দিদির শাসন
কেমন কমাচ্ছে না।
না এই যে আমাদের একাডেমিক পার্টনার জ্যাকসনপাল প্রাইভেট লিমিটেড, ওদেরও একটা ডাইজেস্টন আছে।
জানি তো এখানে তো জল করছে লেখাটা।
ওদের এটা অনেক কম, ডুফাস্টনের থেকে অনেক কম, প্রায় হাফ,
মানে অর্ধেক করতে হবে।
অর্ধেক করেছে। তখন তো মনোপলি ছিল, শুধু মনোপলি ছিল।
আমি দুটো কথা বলবো, ইফ দ্য চেয়ারপারসন কাইন্ডলি পারমিট। সেটা হচ্ছে যে আই কাইন্ড অফ sort of আমি অ্যাপোলজি সিক করে নিচ্ছি, বিকজ this was the first session was on luteal phase defect, right? তো আমি ভেবেছিলাম যে গৌতম তো বলবেই ডুফাস্টনের, আই মিন ডাইড্রোজেস্টনের উপরে বলবে, আমি তাহলে বিশেষ করে ডাইড্রোজেস্টনের কথা বলবো না। তো যেহেতু সেশনটা ছিল লুটিয়াল ফেজ ডিফেক্ট, তো গৌতম তো মানে রোলস রিভার্সড হয়ে গেল। এখানে ইনফার্টিলিটি স্পেশালিস্ট টকড অ্যাবাউট জেনারেল গাইনোকোলজি and I talked about infertility. তো আমি একটু সেটা উচিত, খুব ভালো।
গৌতম প্রথমেই বলেছে আই এম অবস্টেট্রিশিয়ান এন্ড গাইনোকোলজিস্ট।
একদম আগেই বলে দিয়েছে,
গৌতম কিন্তু বলে দিয়েছে।
আমি কিন্তু প্রথমেই বলিনি যে আমি ইনফার্টিলিটি স্পেশালিস্ট।
না
তাহলে একটা মজার গল্প বলি।
So now we have to conclude the first session.
তুমি যেটা বলো।
ওকে, থ্যাংক ইউ।
সরি,
মজার গল্পটা পরে বলবো। আমি কেন নিজেকে অবস্টেট্রিশিয়ান গাইনোকোলজিস্ট বলি, তার পেছনে একটা গল্প আছে, সেটা পরে একদিন বলবো।
ওটা আরেকটা সেশনে হবে। কিন্তু আমি ভাবছিলাম
নেক্সট সেশনে ওয়েট করছে, অলরেডি উই আর রানিং লেট।
ভেরি গুড রেজাল্ট, ডাইড্রোজেস্টেরন উইথ স্টাডি অল।
এটা ঠিক আছে, খুব ভালো লাগলো, কিন্তু সেশনটা ছিল লুটিয়াল ফেজ ডিফেক্ট, ওই জন্য বললাম আর কি। তো আমার একটু খারাপ লাগছে, আমি একটু হয়তো বেশি কথা বলতে পারতাম ডাইজেস্টের উপরে ইন লুটিয়াল ফেজ ডিফেক্ট।
সময় নেই,
যে সাবজেক্টের ডায়াগনোসিস হচ্ছে না তাতে কত কথা শেষ নেই তো কথা।
সত্যি কথা, আই এগ্রি উইথ ইউ। টপিকটাই উঠিয়ে দেওয়া উচিত।
Now we have to call end to this program, and I mean this session. And dydrogesterone is really a wonder molecule, and this whole CME is our academic partner is Jagsonpal Pharma, and they have also such a molecule. Now, so our thanks goes to Dr. Gautam Khastagar and our chairpersons, Dr. Avinash Chandra Roy and Dr. Ratna Chakrabarty. So now we are passing over to our next session that is very interesting, the fetal therapy. And to have with us, we as chairpersons, we have Dr. Shoktirupa Chakrabarty. Yes, she's a consultant, visiting consultant of IRM and AMRI, and chairperson Public Awareness Committee, and a very active member of BOGS. And so, madam, and we do have with us another eminent chairperson, Dr. Siddhartha Chatterjee. He is a very important expert in fertility specialist and director of Calcutta Fertility Mission. So over to and chairperson-elect Hisar Bengal. So now over to the chairpersons for the session.
A very good evening to all. I feel honored and extremely thankful to Professor Gita Ganguly Mukherjee, our beloved Gita Di, to have given me this opportunity. I feel I'm able to pay my offer to as a daughter to my father too. Thank you, Devi, and my pranam to Professor Vaidyanathan Chakrabarty, sir. we now come to a very interesting topic, that is fetal reduction
Multiple pregnancy reduction.
by none other than the young, eminent, brilliant fetal medicine specialist, Dr. Kanchan Mukherjee. And I give the mic over to Dr. Siddhartha Chatterjee, who is also another brilliant ART specialist in Calcutta. Siddhartha, please.
Kanchan is a fantastic orator. When I first heard in one of the meetings on the webinar, I was really surprised how he presented the whole thing in a different way. So Kanchan is a consultant of fetal medicine in Apollo Gynecology Kolkata, Apollo Gynecology Hospital. He has published many articles in peer-reviewed journals. He is practicing in the field of fetal medicine, an expert in ultrasound as well. Now this platform is yours, Kanchan.
Thank you,
Kanchan,
Siddhartha. Respected chairperson.
Kanchan, one thing, Kanchan.
Yes.
I welcome you. Now we're all waiting.
Thank you, Gita.
See how you do it.
Thank you for inviting me to this August gathering. And I must thank you and Shaktirupati especially for inviting me here. And an additional mention to Shaktirupati because the chairperson has called me very young, enthusiastic today. So that made my day, of course. My topic is on multifetal pregnancy reduction. And multifetal pregnancy reduction is mentioned when we have a condition called high order multiple pregnancy. And thereby we mean 3 or more live fetuses in utero, the incidence of which is rising with advanced maternal age at conception and increasing usage of ART, as you all know. Now, they all come with additional complications, both for the mother and for the fetal, like hypertensive disorders of pregnancy, antepartum hemorrhage, low birth weight, intrauterine fetal death, necrotizing enterocolitis, and neonatal death. So the moment we have high order multiple pregnancy, we of course get very worried about all these complications. So what can we do to prevent those complications? And that is our whole idea of offering the reduction to these couples. Now, one line answer to why MFPR is basically to reduce the risk of prematurity and maternal complications. Now, there are clear benefits for quads or more, but the indications for reduction for triplets have been debated because there is reasonable outcome on conservative management for triplets too. Now, whenever you talk about complications, particularly preterm delivery for triplets, then you have to know the background risk if they were managed conservatively. For twins, while 60% would deliver under 37 weeks, for triplets, if they were managed conservatively, 75% would deliver under 35 weeks. So if possible, we must do something about it. So what is the procedure? Well, the procedure is preferably done at 11 to 12 weeks. And we as fetal medicine specialists, we have to kind of blissfully ignore the desperate calls from the fertility specialists, because the moment triplets or quadruplets are discovered, they will keep on saying reduce now, 8 weeks, 9 weeks, but that is not the time, because we have to select the embryo to be reduced wisely. And I will come to that in a minute. There is, I cannot stress more about pre-procedure counseling. That is fundamental. That's very, very important. Until and unless you explain everything at a separate sitting, I think the job is half done. Then we do detailed ultrasound to assess the number of fetuses, position, chorionicity, amniocity, nuchal translucency, and structural defects, if any. All these are not possible before 11 weeks. And then once we have selected which fetus to sacrifice, then we do a 0.5 to 1 ml, 10% KCl injection. We aim intracardiac, but as long as it is there in the intrathoracic, it works. And it is done through 20 gauge spinal needle. Local anesthetic may or may not be used depending on the situation. Now the question comes, why 11 to 12 weeks? Why am I stressing so much on this gestation? Because that allows enough time for spontaneous reduction, which happens in up to 50% of the cases. Now, reliable checking for gross structural abnormalities with the current day and age machine and in the expert hands is very good at that gestation. Having said that, I must say the consent form must also say that there may be defects discovered later on the surviving fetuses. So we are not taking the full responsibility of leaving only the structurally normal fetuses. Now, the similar incidence of preterm delivery and similar birth weight between 11 to 12 weeks and 13 to 14 weeks following MFPR. So you can even stretch it to 13 to 14 weeks, but the moment you are doing at an advanced stage, then there will be more necrotic material left inside the uterus, and you are actually inviting further chances of miscarriage, which is particularly important after 16 weeks. So by all means, try and do before 16 weeks, ideally 11 to 12 weeks, but there would be situations when you have to do it at a later stage, but then the terminology will differ. It will not be called multifetal reduction. Suppose in a situation where you have discovered neural tube defect at 19 weeks in the remaining 2 fetuses, or for the first time in twins, then you are not doing multifetal reduction, you are doing a selective feticide, because you are then reducing one structurally abnormal fetus. Okay. Now the question is, which route, abdominal or vaginal? Well, currently the most favored route is transabdominal, because that allows us better visualization and also lets us avoid the additional risk of infection through the vaginal route. However, you cannot junk the vaginal route completely, because there would be situations like extreme obesity, thick abdominal scar, and abnormal lower fetus, which could not be approached abdominally. In those circumstances, you have to use vaginal route. Now the question is, how do we select the fetus to be sacrificed? Well, it's a combination of factors. You have to go by CRL, you have to go by nuchal translucency, and if there is any major abnormalities. Otherwise, under normal circumstances, when all 3 fetuses are comparable and no problems detected in any of those 3, then you go for the closest to the uterine fundus and the most accessible one. Okay, now chorionicity, that is probably the most important parameter. The most common chorionicity is trichorionic, triamniotic. That's easy. But the problem happens when you have a dichorionic, triamniotic situation, or you have a dichorionic, quadriamniotic. So there can be all sorts of combinations. Now, if you have dichorionic, triamniotic, then reduction of the monochorionic pair is advised, because that is associated with much lower risk of prematurity and better survival rate. All you have to do is inject KCl to one of the monochorionics only. The other monochorionic pair will stop naturally. I mean, maybe immediately, maybe within a couple of hours, but it will happen. Otherwise, you have to question your diagnosis of chorionicity, whether they were monochorionic or dichorionic. If the mother wants only one monochorionic twin to be reduced, that means if they want to continue with twins with the DCTA condition situation, then you have to use some kind of cord occlusive measures, or you can use laser treatment, which is quite expensive and also has a considerable amount of miscarriage rate. And the co-twin may also die in about 15% cases. Now, this is an example of different types of chorionicity. This is an ultrasound picture at 11 weeks. You are seeing trichorionic, triamniotic pregnancy. You can see the dividing membranes very thick, and you can say lambda sign there, there, there. This is a situation quadrichorionic, quadriamniotic. Again, similar to this, all the intervening membranes are very thick, and you can see lambda sign there. Okay, now these are easy. Problem happens when you see this situation. This is a split image on the same patient at 12 weeks. This is a thick membrane with lambda sign, and this is a thin membrane. So this is a situation that I was mentioning so far, dichorionic triamniotic. This is the situation when if you inject KCl into one of the monochorionic pairs, the other one will stop. Okay, much discussed issue on miscarriage. What do we quote? Well, the most data available for single embryo reduction in trichorionic triamniotic situation. And the data would vary from 3% to 7%, 8%. But what would you say? Basically, a systemic review in 2017 said, with expectant management, when your miscarriage rate is about 7%, if you do a single fetal reduction in a TCTL triplet, then it is increased by only 1%. So it is not that high compared to the background risk. What is our local data? About 5 years back, I looked at my own practice when I reviewed 32 cases retrospectively, and I had a miscarriage rate of about 3%. This year, I looked at 20 consecutive cases of quadruplets with Dr. Sujoy Dasgupta and Dr. Kushagrodi Ghosh, and we had no miscarriage in that series of 20 cases. But the chance of preterm labor was still very high. Under 35 weeks, we had more than 50% delivery, but under 32 weeks, it was only 6%. So most of the deliveries were happening between 32 and 35 weeks, which is not too bad. Issue of prematurity. Well, if you deliver trichorionic triamniotic triplets at 32 weeks, if you consider those cohorts, then there will be 35% delivery with the conservative management. But following reduction to twins, it will be 13%. I will mention this data again on the next slide. Median age at delivery after MFPR was about 36.9 weeks. Now, this is the data from Fetal Medicine Foundation, London. Busy slide, I will read only the upper half. Trichorionic triplets, expectant management, miscarriage between 12 and 24 weeks is only 3%. Reduction to dichorionic twins by KCl to 7%. But if the mother wants two to be reduced, that means to continue with a singleton only, then you are putting the needle twice instead of once. Then the miscarriage risk goes up to 10%. So 3, 7, 10. But look at the data here. If you are doing an expected management with triplets without doing anything, your chance of preterm delivery is about 35%. If you reduce them to dichorionic twins, it will be 13%. If you reduce them to singleton, it will be 8%. So the chance of preterm delivery is further reduced with the reduction of more embryos, but you are taking an additional risk of procedure-related miscarriage. And this is the balance that you have to do when you are doing the pre-procedure counseling. It has to be discussed beforehand. You cannot just take the patient on the table and then discuss this. Operator experience is again a major determinant for procedure-related miscarriage. There is data on this even that someone in the initial 10 years would have a risk of 30% miscarriage, but in the same hands, in the subsequent 10 years, it was 11%. So it does matter with the operator skills. Similar improvement also happened in perinatal outcome with increased experience. So what would be the post-procedure care? Well, many of us do use prophylactic antibiotics, but there is no good quality clinical trials and they're used empirically. Analgesics, basically on PRN basis as and when necessary. If the mother is Rh negative, then you have to use anti-D prophylaxis. Now the question is screening for Down syndrome. What do we do? Basically, when their triplets are higher, you cannot use any biochemical screening. Your only option is ultrasound-based nuchal translucency, nasal bone, and all biophysical markers. Many times what happens, we do a reduction, we say do not go for further screening, but when they go to the obstetrician, then they get written triple test or quadruple marker test in the second trimester. One has to be careful that these tests are very high false positive rates and they create confusion, nothing else. Definitely these patients will have very high AFP, and then they come back, even if it is not positive for Down syndrome, they will definitely come back with a positive screening report for neural tube defect. So no biochemical screening test for Down syndrome, please. This is the NICE guideline published September 2019 about prevention of preterm birth. Well, the committee did not make any recommendation on vaginal progesterone for preventing preterm birth in twins or higher. Okay, and they even said do not offer intramuscular progesterone to prevent spontaneous preterm birth in women with twins or triplet pregnancy. All these, Arabine pessary, bed rest, cervical cerclage, and oral tocolytics are very often used, but there is no evidence to back that practice. I think for the parents, this is by far the most difficult part, making an informed choice, particularly when all three fetuses are normal. Then to sacrifice one to prevent preterm birth of the other two is a difficult proposition. And having done so, there is data that 30 to 70% of women experience acute feelings of anxiety, stress, and emotional trauma. So you have to deal with these couples very delicately. However, parental distress declines over time, and this should be balanced against long-term impact. When they take healthy babies home, they get better. So all these must be kept in mind. The final words from me, well, multifetal pregnancy reduction should not be seen as an integral part of the ART program. You must ensure strategies to avoid high order multiples. And whenever possible, please apply single embryo transfer. I understand it is very difficult in private settings like us. It is not a country where the government or the system pays for all IVFs. Here, the patient pays from their pocket. So I know there are compulsions, but if possible, reduce the number of embryos transferred, then we won't have these many reductions in our clinics. Fetal reduction is a last resort. It should not be a part of ART program. Thank you.
Now, thank you. Kanchan.
Yes, madam.
Really, talk is very nice. We are eagerly hearing you talk. It's very good. Thank you.
Yes, any remarks from the chairperson?
Yeah.
I think one of the fantastic presentations Kanchan has ever given. And I'm sure what he told at the end of his deliberation, that this is not a routine part of ART program, that is multiple reduction. We have to be very careful about embryo transfers. Thank you.
Wonderful, Dr. Kanchan Mukherjee. It was absolutely lucid and very simply said. And it is my proud privilege to thank you also as my classmate. And so,
is it?
Yes, yeah.
Kanchan is my classmate in medical.
Actually, Shakti Rupadi wanted to say something, but Didi,
no, the deliberation was wonderful, but we have so many questions due to shortage of time. We've been catching personally later on.
At the end of the session.
Yeah, we have an interactive session at the end. And I must thank the chairpersons also, Dr. Shuktirupa Chakrabarty and Dr. Siddhartha Chatterjee. So now over to our next session, and may we welcome as chairperson Dr. Bulbul Rai Chaudhary. You all know Bulbul Di, a wonderful picture, Bulbul Di, of yours.
Yes.
Yeah, olden days. Yeah. Consultant gynecologist and obstetrician, AMWI Mission Hospital, Kolkata, President Association of Medical Women of India, a very active member and friend, philosopher and guide of Bengal Obstetric Gynecological Society, and our beloved Didi, very much associated with this RN Ganguly Foundation and with especially the public awareness programs. So as chairperson, the floor is yours, and we have, and this is my proud privilege to introduce my another classmate, Dr. Tulika Jha, as chairperson for this session. Professor in Department of OB-GYN, Rampurhat Government Medical College. So over to you, and honorary clinical secretary of BOGS. So over to the chairpersons. To hear very eminent speaker, Dr. Shita Ramutipal.
Thank you, Mausumi, for your kind words. And also, I send my pranams to Professor B.N. Chakrabarty, teacher of teachers. And I also thank Gita Di for calling me as a chairperson to this session. Now, today's speaker is none but Shita Ramamurthy Pal. Everybody knows Shita. She is a loving personality and very much energetic in both in clinics and academics. So she doesn't need any introduction. Anyway, she is the senior consultant of obstetrics and gynae, Apollo Gleneagles Hospital, Kolkata. She is the honorary joint clinical secretary, the Bengal Obstetrics and Gynecological Society. Her areas of interest are fetal medicine, high-risk obstetrics, contraception. Her today's subject is also very nice. That the anemia in fetal anemia is a very, very important one. And I like Tulika to say something.
Thank you,
chairperson,
Tulika. Thank you, Gita Di, for inviting us to chair this session, this important session, and the program is wonderful. We are listening to the whole program from the very beginning. Each and every talk has been very good. And now we are waiting for this very important topic, diagnosis of fetal anemia. And my very dear friend Sita is the speaker. I think this topic has become more important because we know we cannot prevent fetal anemia always. Actually, we cannot prevent it, but early diagnosis and with the fetal interventional therapies, which are now happening in Kolkata also, Kushada is doing, Devasmita is doing, and I know my friends are also doing. So I think this topic has gained more and more importance now. And so over to you, Sita, for diagnosis of fetal anemia. Therapy, I think Dr. Deepika will be speaking. So for the first part.
Thank you, Tulika, my dear friend, and Bulbul Di for the kind introduction, and Gita Di, of course, for giving me this opportunity to share the platform with such eminent stalwarts. So the topic for today is diagnosis of fetal anemia, and as Tulika said, it's a very important area where if it is detected, it can be prevented in few cases, but the most important part is to diagnose it early and treat it early. My screen is visible, right? And thank you. So that's me for you. Thank you. So fetal anemia is a rare but a serious condition. And here sometimes when we talk about fetal anemia, it may be classified based on the degree of hemoglobin deviation from the mean for gestational age, because it varies according to the gestational age. Or we sometimes calculate, as we do with all the biochemical markers, for the multiples of median for that particular gestational age. And it is important to note the pathophysiology of anemia. When it eventually develops into high drops, it doesn't develop until the hemoglobin deficit is more than 7 grams or the absolute value is less than 5 grams. So it really has to be that severe to develop high drops. And our aim in this present day and age is to detect it early before this condition occurs. Now, as I said, there are definitions as to what the fetal anemia would entail. The hemoglobin deviation of less than 2 would be mild, more than 7 deviation, mind you, is severe. Hemoglobin values, which was expressed by Marie et al. About in multiples of median, and a hematocrit of less than 30%. Now, the etiology can be varied, and of course, the most common, and the most we see even now, despite our prophylaxis, is the immune cause of fetal anemia, which is because of alloimmunization, mainly because of the Rh blood group, because of D, C, sometimes rare blood groups like Kell, Duffy. Non-immune conditions can also cause fetal anemia, and that's why we need to be on the lookout. Every time you see a high drops, you should not assume that it is because of Rh incompatibility. It could be because of other conditions. Very common, the most common of them would be congenital infections, where you have the torch group of infections, along with it the parvovirus B19, which again, if detected and counseled properly, can result in proper treatment of these fetuses. Inherited anemia, sometimes rare hemoglobinopathies like alpha thalassemia, bone marrow disorders, again, these are rare conditions, but can be causes of fetal anemia. Hematopoietic malignancies, and rarely placental tumors like placental hemangiomas, or a very big, fetal maternal hemorrhage causing placental abruption due to trauma. Now, whenever you suspect a case of fetal anemia, of course, this is not suspected in routine cases. So this is usually suspected in an ultrasound, or when the baby or the mother gives you a history. But it is important at every point, not only when you suspect it, also when you routinely do an antenatal screening, as to take a detailed family history as to the history of consanguinity, any history of infection exposure, and then a basic blood group and screening test. And we do say that we must not only screen if it is Rh negative, we should also screen for atypical antibodies. And if she's rhesus negative, we must do the ICT, which I'll come to that. Of course, it would be much better if we can quantitatively assess the fetal-maternal hemorrhage by Kleihar-Bethke test, but that's not freely available. And then if we suspect infections in the mother, we need to do serology in the mother to look for IgG, IgM, and to see if it is recent infection, you look at IgG avidity test and for all the infection serology. And then if you suspect and then you want to assess the fetus, you have to refer these fetuses to a fetal medicine center where they can do a detailed ultrasound of the fetus by various methods, the most commonly the MCA PSV, which I'll be talking about. And other things which, apart from the non-invasive, we can do the fetal blood sampling, which again, we don't do it as a part of the treatment. And of course, sometimes if the fetus has anemia, you can pick it up in a non-stress test when the baby has sinusoidal heart rate. And these are rare causes where if you think or suspect, then you have to refer them for a genetic consultation so that they can plan the future pregnancy and then decide accordingly in cases of metabolic disorders. But usually these are detected after delivery. Now, as I said, Rh incompatibility or RBC alloimmunization is the most leading cause of fetal anemia. And it is sad to see that despite standardized protocols of Rh-D immunoglobulin prophylaxis with guidelines, the incidence is still very high, especially in the northern belt, and even here where we see patients coming as late as fetal hydrops, which we shouldn't be seeing in this day and age. And why should this be happening? I think it's because of unrecognized fetal-maternal hemorrhage events, inadequate dosing. It's sometimes given in the gluteal muscle, it has to be given in the deltoid, missed prophylaxis for some antenatal sensitizing events, poor patient compliance, and despite antibody prophylaxis, also some women get it, and because of the absence of prophylaxis for other RBC antigens, and you omit history of blood transfusions for women of childbearing age, but despite being positive, she might have other antibodies. So the pathophysiology in Rh incompatibility, as we all know from our undergraduate days, it's a circulating antigen on the fetal cells, which is recognized by the maternal reticuloendothelial system as a foreign antigen. So the initial response is IgM antibodies, but of course the IgM cannot cross the placental barrier. So on a second time exposure in the second pregnancy, a booster response is occurs, and these antibody-coated RBCs are trapped in the fetal spleen and destroyed, causing hemolysis. And in the baby, in the fetus and newborn, the maternal IgG enters the fetal circulation, destroys the RBCs, and leads to fetal anemia and hyperbilirubinemia. And as I said, a cascade of events occurs, which eventually the baby develops hydrops when the hematocrit falls below 15%. Now, the risk of sensitization depends on the quantum of leak, and even as low as 0.1 ml can cause sensitization. So that is the importance of recognizing these sensitizing events and testing them and giving adequate prophylaxis. Now, the aim of antenatal management in these women is to know the maternal immune status. If she is not immune, you prevent isoimmunization by giving anti-D prophylaxis. But if she's already immunized, there is no point in checking her immunity. And you try and detect these babies for fetal anemia early and treat early so that we prevent the dreaded complications of hydrops. And even if there is hydrops, as we will see, we can prevent the dreaded complication of intrauterine fetal death. So once the lady is ICT positive, which is the most common, which is the test we test for immunization, this is most likely due to the D antigen. But as I said, the sensitizing event may be a non-pregnant event as well, when she's had a blood transfusion or even platelet transfusions because of dengue or some other diseases. And most likely the Rh antigen is the causative factor, but other antigens can also cause ICT to be positive. And then you detect the antibody test by either qualitatively or quantify this, but that is more expensive. Now, in a Rh negative mother who is ICT, is a critical value. And what is this critical titer? This is the value below which no cases of fetal hemolysis has been reported. And this is ideally determined by the lab. So though we say there is a critical value of 1 in 16, if the mother has had a history or a previous baby, we don't rely on these titers at all. Or rather, if the titer is positive, we would rather not go by the critical titer because that can vary, and the titers have poor correlation between the fetal affection. So once the titer is positive, we fetal medicine specialists would directly go and assess the fetus rather than wait for the critical titers. And this also is there's a dilemma because there are two methods of measuring these titers, the tube method and the gel method. Though the critical titers have only been established for the tube method, most lab test by the gel method, which is more sensitive, reproducible, and stable. So the bottom line is, if she is ICT positive, you refer her to the fetal medicine specialist. Don't wait for any specific critical titer. And then, as I said, once the critical titer is positive, the earlier on when we used to rely on the serial amniocentesis to detect the bilirubin levels, and then a spectrophotometry was used to quantify these bilirubin levels, and these values were then plotted on the Lilly's curve or Queenan's curve and all that to predict fetal anemia. This was invasive and not reliable as well. And so now MCA, that is middle cerebral artery peak systolic velocity testing, has replaced serial invasive testing. And this is a very reliable non-invasive test to detect fetal anemia. So as I said, in a previous a baby who's ICT positive or a previous affected pregnancy, there is no point in doing any of this. We directly go in for an ultrasound monitoring, and you start monitoring 10 weeks before the last mishap, or you do it after 18 weeks weekly to assess the fetus for MCA Dopplers and pick up those fetuses which show signs of fetal anemia and act accordingly. So MCA Dopplers is what we do. And here we don't look at the PI or the resistance index. We look at the peak systolic velocity. It can be done on any vessel, but why MCA? Because that's most reproducible. And the physiology behind this is the hemolysis causes anemia and less viscosity. And that causes a hyperdynamic circulation, which is reflected easily in the peak systolic velocity. And the values, again, are not, though we have a easy method of detecting, but they are actually converted to multiples of median, which are gestational age dependent. And according to the gestational age, we predict whether this baby is having fetal anemia or not. So we have calculators like the perinatology.com or the fetalmedicinefoundation.com. All those calculators, we just have to put in the values, the gestational age, and that will give you the multiple of median. But any multiple of medians of more than 1.5 indicates this baby has severe anemia, or a rough estimate would be any peak systolic systolic velocity, which is more than twice the gestational age. So the baby is 24 weeks. If anything more than 48 or 50 would indicate that this baby is going in for fetal anemia. And it's important, again, like any other parameters, to look at the trend of the PSV rather than absolute values. And these have been time and again proven to show, and the recent meta-analysis also has confirmed that the sensitivity and specificity is very good. And we have reports confirming that if treated, the fetuses have very good outcome. Now, these MCA Dopplers are not very useful before 18 weeks because the reticuloendothelial system is too immature. And again, it's not a reliable predictor of severe anemia after 35 weeks. So, and it's been found to be similar or better than what we used to do for the amniotic fluid optical density of 450 in prediction of these fetal anemias. And it's a very easy thing to do. Of course, there are specific criteria, which I'm not going into details, which are more for the people who are doing it, but it is easy, but it is very sensitive. So you have to be careful in how you do it and interpret it as well. So these are typical values, and this is a baby with high drop showing fetal anemia, which recently in our hospital was treated by Kanchan as well. So, and as I said, in previous affected pregnancies, you started at 16 weeks, and around 20 weeks and around 20 weeks with no previous affected pregnancy, and it's done 1 to 2 weekly depending on the severity. So this is typically an MCA Dopplers, which is a normal Dopplers showing at around 31 weeks, and then this is how the different criteria that we use for assessing the peak systolic velocity. Now, this is a chart which shows a rough idea as to what should be the peak systolic velocity at different weeks of gestation. So, as I said, a crude method would be just to double the gestational age, and if anything more than that would be an indicator for a fetal anemia. So the rough criteria would be that if you do the peak systolic velocity, if it is less than 1.5, you monitor them and deliver. You can safely deliver them at 37 to 38 weeks. But if it's more than 1.5 moms, and if the baby is more than 35 weeks gestational age, it's better to deliver them. But if it's less than 35 weeks, we need to treat them with intrauterine transfusions, which we'll be hearing from Professor Dey. So of course, there are changes on ultrasound, which are late changes, and we shouldn't be ideally waiting for these changes to happen. But sometimes we do get these changes, like the one I told you about this patient. And the severe diseases, when that happens, the ultrasound would show features like placentomegaly, liver or spleen enlargement, polyhydramnios, ascites, and fetal hydrops. But once the hydrop sets in, the survival is still there. 40% survival is there, and we can, if we act even then, these babies can go home. And one such typical example was this baby who recently had transfusions and went home fit and well. But of course, the survival doubles when it is non-hydropic. So again, the key message being that you have to pick them early and treat them early. Of course, in specific clinical conditions, which are other causes of fetal anemia. So again, to mention that once you see hydrops, you should not assume that it is because of RH incompatibility. You have to rule it out, of course. But there are other conditions where you would find other changes, like similar to the RH incompatibility, like placentomegaly. In alpha thalassemia, you would have cardiomegaly. In infections, you would have other features like ventriculomegaly, intracranial calcifications, growth restrictions, early onset, and ecogenic bowel. And of course, with twins, when you're doing treatment, when you're doing a laser treatment for twin-to-twin transfusion, and then the babies have twin anemia polycythemia sequence, where you have discordant, when one baby is polycythemic and one baby is anemic, where you have conditions of fetal anemia, where you can diagnose it by a discordant MCA PSV, where the donor has more than 1.5, that's anemic, and polycythemia in the recipient. And of course, that would be other signs like discordant placental ecogenicity and starry sky appearance of liver in the recipient. So the key messages here is RH isoimmunization is the most common cause of fetal anemia. And the non-invasive prediction of fetal anemia has actually revolutionized the management or the prediction, and the IUT has revolutionized the management of fetal anemia. So it's important to refer these mothers and fetuses to a fetal medicine specialist who are with expertise in fetal blood sampling and intrauterine transfusion, especially when the MCA PSV measurements are more than 1.5 moms. And with the introduction of these IUTs, the fetal survival has been reported, excellent survival has been reported, approaching 90 to 95%, and as I said, in experienced centers with excellent long-term neurodevelopmental outcome, even in the context of severe fetal hemolytic disease, which we will hear from our next speaker. So thank you for your patience here.
Thank you, Sita, for your excellent deliberation. And really, even now, the RH isoimmunization, we are getting patients of RH isoimmunization, which is a really sad thing of affairs. Now, Tulika, if you want to say something.
It was very clear, very lucid, and it's a difficult domain, but you made it look easy, and we are waiting for to answer some questions. I think there are a few in the chat box, but then we can handle them after the next talk. And over to Mausumi for the next session.
One thing, Shita, one thing, I'm so glad that BOGS has so many young are coming up with so
again, she's made our
academics.
day by saying young. Thank you, Didi.
No.
Yeah, really
Today's
young.
faculties are a combination of young and senior and junior. But
Thank
to
you,
me,
Didi.
all are so young. I'm so happy that you're doing so well in all spheres. You know why I have kept that subject? Because in my practice, recently I got 2 or 3 fetal anemia. And they said, and they went other places. I said, why? There are so many consultants are here in Calcutta. So why are they going away? That's why I've said, you must know that all of you are doing so good job. Thank you. Thank you very much. Now,
Thank you, Didi.
Deepika.
Thank you. Thank you, Sita, for your wonderful presentation, and very nicely said. And thanks goes also to the chairpersons, Bulbul Dey and Tulika. So now, a very much awaited session, our last session of the day. May I call the chairpersons, Dr. Shukanto Mistro. The present designation is the Professor and Unit Head, Department of Obstetric Gynecology of WIMS, and past President of BOGS, with interest in medical disorder of pregnancy, critical care in obs and gynae, vaginal surgery and contraception, and is a very well-known teacher and gynecologist of Kolkata. So the floor is yours, and it is my proud privilege to introduce another very dynamic personality, Dr. Banerjee Mukherjee, Vice President of BOGS, Honorary Secretary. Honorary Secretary of he is a Vice President of BOGS and also the Vice President of FOXY at present. He has got many awards and many publications. And so over to Basho. So Basho and Shukanto for the chairperson.
Thank you.
And we have with us a very well-known speaker. And really, madam, we are very much grateful for your consent to be with us in today's forum. And for introducing you, it is the job of the chairpersons.
Now,
Gita Di.
Shukanto is at present is the president of ISOPAR Kolkata chapter. And I told Shukanto, do something so that ISOPAR in Calcutta becomes very important.
Thank you, Didi.
And Basho, what I tell about, welcome you, Shukanto. And Basho, oh, really, when I told about Basho, I said, look, he's doing so good and we don't know where he'll end. I hope you go up and up and up.
Thank you for your blessings, but not too much up, but thank you very much.
and about
thank you.
Deepika.
Yeah.
Deepika Deka. Really, Deepika, I really welcome you. We are all waiting to, it is your subject, your specialty, and we are all waiting to hear from you. Now you introduce.
Thank you, Didi, for involving us in this beautiful program. And as a matter of fact, it's my proud privilege to introduce Professor Deepika Deka, who happens to be my old dear friend. She was a senior consultant, fetal medicine and genetics. And so far I know, she was one of the pioneers in the field of fetal medicine in India. And as you know, she was professor and unit head in chief of the Maternal Fetal Medicine, AIMS, New Delhi, Vice Chancellor of SS University at the present point of time, Government of Assam. She was Director of AIMS Kalyan, West Bengal, and she had many other publications. I could see 258 publications, national and international, edited 5 books, and chapters she had in different books, it's about 60. So I can continue for minutes together, but I'm sure everyone is interested to listen to her wonderful work. Bashab, please add a few more lines, and then the floor will be to Paul.
Yeah, I think we're coming in between Dr. Deepika Deka. As you rightly said, Shukanta, the pioneer in fetal medicine in India. I think she's, fetal medicine in India is synonymous with her name. I think there's nobody in this audience who does not know about her, hasn't heard her before, but it's a pleasure. From the RN Ganguly Foundation, we welcome Professor Deepika Deka, and would like to hand over the floor to you, Dr. Deka, to carry on your presentation. Intrauterine fetal transfusion is what we're speaking of.
It's a topic.
A very good evening to everybody present here. First of all, I would like to thank Dr. Professor Gita Ganguly for inviting me. And I think this is the second time that I'm taking part in this forum. Yes. And of course, to be chaired by my good old friend, Dr. Shukanta Mishra, and young budding to-be president of Foxy. I know this is what Dr. Gita Ganguly meant. I wish you all the best. I wish everybody all the best. Yes, today has been a day of webinars, ISOPAR and AOGD, and now this one. So I will go straight to my talk. My topic is intrauterine fetal transfusion.
Yes.
So I was not very sure whether it is blood or it's something else. So we are now talking of a patient who is in utero and has been given an individual status irrespective of the mother. So it's got its own individuality. And the various type of transfusions that we can give are blood, we can give platelets, and we also have been giving some medicines. And I will be talking today about IVIG because of the trend of what was discussed. I think Sita has made my job easier because she has also listed the various causes of anemia, of which the commonest, of course, is rhesus isomerization. Sorry. But we have done a lot of cases of parvovirus infections also. And of course, the other conditions are really not to be done because they would rather be. So she talked about Rh negative mothers. When they carry the Rh positive fetus, the RBC goes into the maternal circulation. It excites an immune response, and these antibodies come back and destroy the fetal cells. And then the fetus becomes anemic. So the baby, the least is that the baby could be not affected, have mild jaundice, or the baby could be having kernicterus. Or the baby could be landing up, as in this one, with a gross fetal hydrops, which would ultimately lead to fetal death. So when we talk about anemia, Sita has already showed that you can talk about the various degrees of anemia, the various grades of anemia. So like in an adult, you have anemia, you give iron, of course in the fetus you cannot give, and you give blood transfusion when it is severe. So similarly, it is done in the fetus. And this is a very non-invasive way by which we can diagnose fetal anemia by doing the middle cerebral artery peak systolic velocity. In this patient of ours, you can see, as Gita had said, that it is, Sita had said it is about twice. Here, this is almost 80, the middle cerebral artery. So we follow this by follow cases of Rh isomerization by middle cerebral artery peak systolic velocity, which will pick up the fetal anemia much earlier and will prevent the development of a hydrops fetalis. When I started doing IUTs at AIMS, we were doing almost 90% on hydropic babies because everyone was monitoring the babies at home in their clinics, and they would refer to us only when the baby was hydropic. But I think after traveling around and informing things that we could diagnose earlier, then now the patients are coming at a much earlier state, and therefore the prognosis is much better. Earlier, we were doing amniocentesis, as Dr. Sita had said, But for the last 20 years, we have not been doing amniocentesis for spectrophotometry, because for that you would again need to put in a needle, which would again increase the fetomaternal hemorrhage. And that was an indirect way of knowing whether the baby was anemic. So we totally now rely on the middle cerebral artery peak systolic velocity. It requires a lot of skill. It's not so easy because you can get any level, any way if you do it. So it's very important to go to the circle of Willis and pick up this vessel which is going upwards, take it nearer to the base, and then see the middle cerebral artery. Peak systolic velocity. So there is very strong recommendation to say that middle cerebral artery should be the way of diagnosis of fetal anemia. Now the management earlier on in the 60s, and even when we first joined AIMS, you know, we used to deliver them early. We even did plasmapheresis for acute cases. As soon as the pregnancy reached 28 weeks, we delivered and handed over the problem to the neonatologist. But now, with intrauterine transfusion, initially it was done by Charles Rodek and Kypros Nikolaidis by the fetoscopic technique. But very soon, because chordosynthesis became to be done, so we started doing intrauterine transfusions by the cord blood technique. We initially started with intraperitoneal, but very soon we shifted to the intravenous technique. Later on, we came across a lot of data saying that maternal IVIG therapy could be very useful for the prevention of fetal anemia and also for the treatment by direct fetal IVIG. This was a thing which I had started at AIMS, and we found very good results I will be discussing. So I would say that the big thing is that RH isonize cases, as soon as the indirect Coombs titer is more than 1 in 16, which is a critical titer in most places, the patient should be referred to a center where there is a facility for doing expertise for doing intrauterine transfusion, not just monitoring, transfusion. And there should be a neonatal ICU with expertise in exchange transfusion. There should be a good blood bank. I know of centers where 1 unit of blood costs 10,000 rupees. I mean, that's not what we want. And most importantly, we want that the obstetrician should refer the patients before hydrops develops. So we do the indirect Coombs test in all Rh negative women at the time of booking. If the titer is between 1 in 4, 1 in 8, we are not very worried. We do the titers every week. And then, but when it reaches 1 in 16, there is no point repeating the titers. We have to now treat this woman as a fetus which is at risk of severe fetal anemia. And then we do monitoring. And then, of course, as soon as we think that the baby is severely anemic, we do intrauterine transfusion. This is a fetus referred with a very big placenta because there is placenta-megaly because the mother's way of trying to get more blood for the fetus. And here you can see this is the heart, this is the liver which is floating in the ascites. This is because the baby's heart has failed because of anemia. The liver is also having hypoalbuminemia now, and these are the causing hydrops in the baby. Sita has already told you how we detect. So at the period of gestation on the left side, at 24 weeks, for example, if you find that the middle cerebral artery peak systolic velocity is 50, that means the fetus is severely affected. Now the baby needs blood transfusion. So we do a cord blood sampling with a setup ready to go on with a fetal transfusion if necessary, for which we will need O negative blood, centrifuged, and now this is Charles Rodek and Kypros Nikolaidis, who first did intrauterine transfusion through the fetoscopic route. But though it came with a bang, it disappeared very quickly because of the risk of the fetoscope and because cord blood chordosynthesis came in. The percutaneous ultrasound guided technique came in just the next year and could do the same thing with less invasion. So cord blood sampling is done when the middle cerebral artery peak systolic velocity is more than 1.5 multiples of median, the fetus is lesser than 34 weeks, or if there is hydrops fetalis. So if there is hydrops fetalis, we don't want to do anything else. We go straight in this as an emergency. And we do intrauterine transfusion as an emergency. So what we initially do is we put in a needle through the ultrasound guidance, through the maternal abdomen, into the umbilical cord. And this umbilical cord site could be anywhere depending upon the expertise or what we are used to. I normally like to go to the cord insertion into the placenta, because here the cord is, doesn't move too much because it is adherent, just coming out of the placenta. But we can sometimes, if this is not accessible, we can go to the free loop of the cord, and many people like to go to the intrahepatic portion of the umbilical cord. So this is called the cord which is on color Doppler. We can see very clearly coming out of the placenta, and we do the cord blood sampling. So the initial cord blood sampling is done for the hematocrit, and before the first transfusion, we take a little bit of blood, 1 to 3 ml for the blood group, the hematocrit, and the ABO-RH grouping. After that, we go in for the transfusion. We immediately do a hematocrit on the side table, and usually it is less than 30. We calculate the amount of blood to be given to the fetus depending upon various formulas available, which again depends upon the period of gestation, the degree of fetal anemia, and we start. The blood that we need, we take O negative, which should be CMV negative tested. It should be fresh. We don't take blood which is more than 72 hours old. And it should be leukodepleted. They should be tightly packed. This is a top-up. It is not an exchange transfusion, which we used to do earlier. Because with a top-up, there is no risk, much risk, because we are not giving only to the fetus. We are giving the blood to the feto-placental circulation, which is 150 ml per estimated fetal weight, kg weight. The optimal volume of blood, as I said, depends upon the hematocrit at sampling. So if the baby is anemic, it will need more blood. Presence of hydrops, however, is a contraindication. We give very less amount of blood. Whatever amount that we need to give, we divide into 3 quotients. So we give the first quotient, and then we give the second quotient after 48 hours, and the third one after that. If we give the full amount of blood at the time of the first transfusion, because the baby is already having cardiac depression, the fetal heart can stop. The final target in the books is written as 40 to 50% of the PCV, but what I normally do is we go above to 50 to 55% PCV, because then, if you give 55, the fall is around 1% per day, and to come down to 30 would need another 3 or 4 weeks. So for 3-4 weeks, we don't have to give a transfusion. So higher levels of the post-transfusion hematocrit will allow a longer interval between the IUT, because each transfusion technique is a risk. So under ultrasound guidance, the needle is inserted through the maternal abdomen into the fetus. So this is of course showing an intraperitoneal transfusion in a very early pregnancy where access to the cord may be difficult. But nowadays, most of them do it the intravenous way. So we can do it only when the fetus is very small, where it is difficult to do a chordosynthesis, but intravascular transfusion is the preferred method, especially in hydropic fetuses. So I will show you the video of the transfusion later on, because I don't know, something's wrong here, it's not coming. So let me finish off with my presentation. After the first IUT, we do the post-transfusion hematocrit, and depending upon that, we will do the next transfusion if and when required. We do the last transfusion around 34 to 35 weeks so that we can deliver the baby at term. Earlier on, we were doing transfusions not after 28 weeks, and we used to deliver the babies at 32, 34 weeks. But now with increasing expertise, and if with better machines, we are doing the last transfusion around 33 to 34 weeks, and we are delivering these babies at term. So the success rates in most units all over the world is almost 80 to 90%. And this study of ours, which has shown that the survival is much better in non-hydropic fetuses compared to hydropic fetuses, and this data of ours is as at par with the best centers in the world. So we can say with great confidence that we are able to save almost 94% of our babies. There can be complications, especially in the hydropic fetus. When we put in the needle, there could be bradycardia, but we therefore give atropine. The baby could be moving around, so we paralyze the baby with panicuronium so that they don't move. And as we said that we had some fetal deaths, and we do keep the later weeks of pregnancy, beyond 28 weeks, we do the transfusion in the OT, so that if required, if there is prolonged bradycardia, we go in immediately for a cesarean section. So we have blood ready, and we have the neonatal lozenge also ready to resuscitate the baby. So the neonatal outcome after fetal anemia has been found to be quite good. And routinely we do the audiometry, neurological development we see, we check them up for anemia, and we find that the risk is not very high. The other method that we have used is transfusion by the intravenous immunoglobulin therapy. I have already talked earlier about IVIG therapy given to the mother. Now we are giving IGIV therapy directly to the fetus because it is a very costly drug. And if you give it to the fetus, which is much smaller, we need to give just about 10 to 15 ml of the IVIG. How it works is that it blocks the FC receptors, and then it blocks these RBCs from getting hemolyzed. So we did that in several cases. We did several studies, and we have found that intravenous immunoglobulin therapy can delay the onset of fetal anemia, reduces the number of transfusions, and is very, very useful in the management of rhesus isoimmunization. So this was during my WHO fellowship at Georgetown University, Washington, DC, with John Quinnan. He is the pioneer in fetal transfusion for RH isoimmunization. And this is Sacker, who was the person who first described intravenous immunoglobulin therapy in patients with rhesus isoimmunization. So we have done direct fetal intravenous immunoglobulin as an adjunct to using it during transfusion. And we found extremely good results. We have published our data in Fetal Diagnosis and Therapy in 2013. It was a thesis of Dr. Aparna Sharma. And we find that this really delays and is very useful in the management of rhesus isoimmunization. And of course, I thank Professor Kamal Bakshi and Professor Kripros Nikolaidis, with whom I was an ICMR Senior Scientist Fellow for fetal endoscopy. And of course, I visited him every time I go to London to just update myself. And a lot of things I learned from him on intrauterine transfusions and of course, fetal endoscopy. So thank you all very much for a patient hearing. And I would like to now share my video on rhesus isoimmunization. Okay, so here we are doing the ultrasound localization of the fetal cord. We use a bigger needle because we are going to push blood. You see that's a very big placenta because of the placenta-megaly. The needle is being inserted under ultrasound guidance to the umbilical cord. I like this part of the cord because it is steady and it is near the insertion. But it depends, we have to find. And then we directly push blood. This blood has a hematocrit of 75 and we are pushing it. This is blood going through a free loop of the cord. You can see that this is a posterior placenta. The fetus is obstructing the view. And you can see the turbulence in the cord as blood is being pushed.
Yes.
So we push it at a rate of about 5 to 10 ml per minute. This is a color Doppler. This you can see is a very early pregnancy. This is a needle which is going to enter with a sharp thrust.
DIVATRONE,
It enters the umbilical cord, after which we directly push in the blood. We don't do it by drip. We push it with the syringe because it needs a lot of force. In fact, the assistant pushing it, their fingers will be sore after this. And you can actually see the RBCs going down. You can see the blood in the other loops of the cord. This is a difficult case. It is a posterior placenta. A needle has to go a long way, need a different type of a needle. The cord slips, and it is very difficult to really enter the cord well. Managed to do that. Now we take out the stellate, we take the blood, and we now pushing the blood. This is hardly an 18 weeks pregnancy. And you can see the blood flowing through the cord, and needle is taken out. And before taking out the needle, we take the post-transfusion hematocrit, and we check the fetal heart activity at the end of the procedure. At the end of the procedure, we do the hematocrit so that we know when to do the next transfusion. So thank you all very much. When we do intravenous immunoglobulin transfusion, we take in the syringe, 10 ml syringe, we take 8 ml of the blood and 2 ml of the intravenous immunoglobulin, mix it up and push it into the cord. So this is a very delicate procedure. It needs a lot of expertise. However, the number of cases referred are increasing because, as the pediatricians say, they know that we are able to save these babies, and intrauterine fetal blood transfusion is the only way we can save the lives of these very high-risk babies. Thank you all very much.
Thank you, Dr. Deepika. I think that was a really wonderful insight into some of the frontiers of fetal medicine. We would say intrauterine fetal transfusion is, as you rightly said, increasing, and there's more expertise in all the fetal medicine experts in the country gradually developing in this field. Dr. Shukanta Mishra, Professor Shukanta Mishra, for your comments before.
Thank you, Dr. Deepika Dekar. As a matter of fact, you were wonderful. Yes, only the experience can give you a lot of skill, and what you have started is being followed across the country by many, and you are the pioneer. And thank you very much for sharing.
Dr. Bakshi was the pioneer. Dr. Bakshi was the person who did the first intrauterine transfusion as early as 1982. I joined her as an assistant professor in 1988. She saw me doing ultrasounds and she said, "You have a knack for doing ultrasounds. You develop fetal medicine." She made Alka Kriplani do endoscopy. I was very interested in endoscopy, but she wouldn't. She said, "You develop fetal medicine." And she made Dr. Mittal develop ART. So that's how we started. Dr. Gita Ganguly knows. We were doing it in a 10 by 10 room. There was no place. And we started it, and now it's a department.
So it's a journey. Yes. It's a journey, and you always enjoy the fruit at the end of this journey.
Momtaj Ji want to say something. Momtaj Ji, you want to say something?
Yeah. So, very nice to listen to Deepika, and I am listening or seeing the things with her for many long years, if she remembers. And
yes.
Yeah. And
I think you have come to my OT also.
We tried, yes. we also in the venture, we tried to do these things in medical college also, but you know, the setup was never there in that way. Anyway, so I'm very glad I listened to you today also, and thank you very much.
Gita Di.
Hello.
Gita Di.
Yes. Deepika, I know Deepika for many years. I used to go to games so many times, and I saw Deepika and all this. You are assistant professor that time, I think.
Yes, I joined as an assistant professor in 1998. Yeah? Before that, as a senior resident, you have seen me.
Yes. So I don't remember since when I have seen you, and I know that you are doing this thing, and Kriplani also they were there. I used to go and as an examiner for so many times, so I don't remember now.
Yes.
And Kamal is really my good friend, and they used to call you and say, "Oh, they are starting the new department." They are so happy. Really very happy.
We have started, madam, our division of fetal medicine. That was way back in 2012. And now we have started fellowship. We are doing routinely endoscopy. But now I retired in May. and I've joined private practice.
Oh, then what will happen?
And always,
You
she
start-
is
I'm now
always so
developing,
loving person.
in
Yes.
Cloud9, they have asked me to develop the department, so I'm developing.
Yeah, do this, develop it so that everybody will be benefited, isn't it?
That's good
Yes.
news.
Now, Deepika, we are so happy that you have come here today.
And thank
And
you,
our
madam,
lovely-
for inviting me. It's a pleasure.
know-
So nice to see everybody.
Yes.
Dr. Mamtaz, the Shukanto, I'm seeing you after ages.
Af-
Ashish, I think I
after-
met you recently. Ashish, I met you somewhere recently.
Yeah.
After 2 years, maybe, Deepika.
And another, this thing.
The last
seminar.
AICUG, I think we met.
Yes.
We had photographed in the last
anyway,
AICUG.
we want to hear you again and again. I will call you again.
I'll be thrilled.
But that time it will be physical, not
Yes,
virtual.
yes.
We are fed up of
Typically, yes.
virtual.
Yes.
You know.
I cannot forget the examinations that I took in Calcutta and the fish and the food at lunchtime.
Yeah.
You
We
remember
have
that?
this food
Sweet.
again.
You remember
When we
that?
do it in
Yes,
physical.
and Sarla Gopalan and I, we had a nice time.
Yes.
I remember my trip to your bungalow, the director's bungalow.
No, nice memories, sweet memories.
Nice memories,
Yes.
Thank you, madam. It was a very mesmerizing lecture and wonderful presentation. And it is a great opportunity to have you today, being the pioneer of this fetal therapy. And so as all good things has to come to an end. So we are calling an end to this wonderful session. And I don't know, thanks is a too little word for you, ma'am.
I will give the thank
you for
afterwards,
inviting
after
me.
I say
Thank you very
something.
much. It's been a pleasure.
Moshumi,
Yes,
you
our
give the,
thanks
vote
goes
of
to our
thanks. But I want to
chairpersons.
say something. After that, you give the vote of thanks. Okay.
Okay.
Now,
Thanks goes to
not
Dr.
now.
Shukanto Mishra and Basho.
Yeah.
Dr.
sharing
Mausumi,
this
Dr.
session.
Gita Ganguly wants to say something.
Yes, definitely, ma'am.
No, I told, my sincere thanks to Professor B.N. Chakravarty. At this age, he came so early and was present, talked to many, and blessed everybody. Just very good.
So nice.
Yes. And
Yeah, you all are inspirations for us.
Absolutely, absolutely.
yes. And another thing, this CME started before 4 o'clock. Now it is nearing 8. About 4 hours is going on. But everybody, I'm so happy to see all of you are present.
Yeah.
Really. Why? Because the deliberation was really very good and effective. And I'm sure the viewers will be very much benefited. My thanks goes to all the chairpersons and the speakers. Ratna, you are also present from the very beginning. And Shita, Moshmi, though Bashav has come late. But anyway, she was very busy. I thank all the chairpersons and the speakers. Another things, our academic partner, the Jagsonpal Pharmaceutical, and their medical advisor, Dr. Deepika Chabra. She was also present from since 3:30.
Yeah.
And organized this thing. I'm so
Yeah, Gita,
happy.
we could convince Dr. Deepika Chabra that there is another part of India called the East, because Dr. Jagsonpal was located in the North for a very long period of time.
Yes, now they're coming here.
For the last couple of years, Gita Di, Dr. Deepika Chabra has understood that there is another region in India called the East, and now it's so important that in the last couple of years, Jagsonpal is very much in the prominence, and thank
Yes.
all of them.
Anyway, they
Now
have,
we are looking
now-
for opportunities in the East. Please
Yes,
do look
and
at
Dydrogesterone, they have got a molecule Dydrogesterone, DIVATRONE. I have used it for last few days. It's very good. Anyway, I thank them also, that Jagsonpal, and ask them to do more this thing and reduce the price also. Though their price is much less than others, but reduce it more so that we can use it more and more. Anyway, now Dr. Mausumi Banerjee for giving the formal vote of thanks.
No,
now,
madam,
on behalf
before
of
giving
RN
the-
Ganguly Foundation, I thank everybody.
Before giving the vote of thanks, madam, there is a interactions that I see in the QA box. And there is question from Dr. Nidhi saying, can you do intrauterine transfusion in non-immune high drops diagnosed at 25 weeks by USG?
Okay.
Okay. Non-immune high drops is like having fever. You know, you say fever. So what you're going to do? There are thousands of causes causing non-immune high drops. So one of them could be anemia. So you really have to do first a workup. And if you find that the cause of the non-immune high drops is anemia, which could happen in cases of parvovirus infections or a massive fetomaternal hemorrhage, or of course, we don't see much of alpha thalassemia here. In those cases only, the blood transfusion will be useful. But other cases, you know, which are genetic causes, which are not very compatible with life, there is no point. So you do it only when the cause is anemia.
There is another question again from Dr. Nidhi saying, the method to reduce the risk of multiple pregnancy in ART procedures.
One thing, before you give vote of thanks, the company, Mr. Progesterone Guhur, say something.
Yes, madam, there is a slot for them.
Yes.
There is the, let this question be answered.
Yes. All the questions you do it, then after that.
Yes, yes,
Mr.
yes.
Guhur.
So method to reduce the risk of multiple pregnancy in ART.
Single embryo transfer.
Yeah.
Yes.
What
is Kanchan?
Mausumi, ART
Single
specialists
embryo
are not
transfer.
there.
No, but single
Kanchan,
embryo
where is
transfer, he
Kanchan?
already said it. Yeah.
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 Kanchan mentioned the single member transfer only.
So
but just before joining here, I was also in another AOGD, you know, meeting where they were doing ART. So apparently it is not very simple doing single embryo transfer in private practice.
Yes.
You need to give 2 or 3. So I don't know how you're going to do that.
Yeah, that is a challenging thing, challenging.
But I know that in AIMS you only do single embryo transfer.
When
So
one
is
has
there any
to
other
spend money
questions
from
from the
his
floor?
own pocket, it's not possible.
Any other questions from the floor?
It is possible if you just stick to blastocyst transfer, then you can think of doing single embryo transfer.
Then again, the
And
success rate reduces.
And I mean, very young patients, you can go for it. That's not a problem.
Yes. So if there are no more questions, so it is it's a great, I mean, the vote of thanks part is already given by
but before that,
madam, already given by madam. And I thank madam to involve me because she has involved me in this
Mausumi,
session. I
first the
request,
company speak something, then you give
yes,
the vote
yes,
of thanks.
I request
Progesterone Guhur.
people from Progesterone Guhur from Jagsonpal Pharma to say a few words and about their products. Probably they have a video, and also to deliver the vote of thanks from their part.
Introducing, for the first time in India, micronized Dydrogesterone, DIVATRONE. For a safer and smoother journey to motherhood, Jagsonpal Pharmaceuticals is manufacturing all the active pharmaceutical ingredients and intermediates concerning Dydrogesterone, making India self-reliant. Atmanirbhar Bharat. Vocal for local. Go for DIVATRONE.
Good evening, respected doctors. I myself, Progesterone Guhur, Zonal Sales Manager, Jagsonpal Pharma. With this web symposium, we have the pleasure to share with you the development which Jagsonpal has made in the recent time with the drug so frequently used by your specialty, that is Dydrogesterone. Brand name is DIVATRONE. With DIVATRONE, Jagsonpal is proud to have the India Atmanirbhar for critical API of Dydrogesterone. Till now, the API was imported. Now, we at Jagsonpal manufacturing the API in the country after many years of R&D. The cost has got lowered remarkably. Just 50 rupees per tablet. We look for forward for your support for DIVATRONE. Thank you. Good day.
Yes, thank you. So our thanks goes to all the eminent faculties throughout the day, and especially we must thank Madam, without whom this, I mean, she went on doing this RN Ganguly Foundation, be it COVID, be it non-COVID situation, and she has now taken up the challenge of the virtual programs once the COVID situation started. And wonderful programs and have been done. I've already presented the RN Ganguly Foundation presentation at the very onset. So thank you, Madam. Thank you, Madam, for involving all of us. And special thanks goes to our teacher of teachers, Professor Bodhana Chakravarty, as a chief guest of this program. As a special guest, we had with us Dr. Mamtaz Shangamita. And I'm not mentioning all the names, but all the eminent faculties as chairpersons and speakers, they were wonderful. Our special thanks also goes to Dr. Deepika Deka. In spite of all the busy schedule, she is with us. And also it goes to the pharma company that we have with us today as an academic partner, the Jagsonpal. And I request, thank you to be with us as an academic partner. Hope we will all support you and with your wonder molecule of dydrogesterone. And now over to you for the vote of thanks. I must thank Dr. Deepika Chhabra also.
Prasan Guha has spoken. Mr. Shubhajit.
Yes, good evening to all my respected doctors. I am Subhajit Kundu, Regional Manager, Jagsonpal Pharmaceuticals. We thank the organizing committee for giving the wonderful opportunity to introduce DIVATRONE to you all for the estimated gathering here for today. So from my core team, Mr. Proshungo Jeresem and Mr. Amit Saxena from the digital wing, and obviously Dr. Deepika Chhabra ma'am from the GM Sales Medical Service, join me to thank all the respective faculties and the attendees presented with us today. And also we look forward to your presence in our further programs always. So thank you very much. Thank you so much.